Okay.
Sir, you are live. Good to go.
Yeah. So once again, good morning to all the uh, members of this Retina Interest Group of Chennai. And at the outset, I would like to thank all of you for joining on a Sunday morning during this intense lockdown in Chennai, but it's free for rest of Tamil Nadu. And this meeting was planned in such a way that we always look forward to the institutes for any new treatment. We always call our institutional friends for any new treatment protocols or any change in management or any procedures. We always look forward for some feedback from the institute friends. So similarly, for this pandemic, see, a lot of webinars and lectures were given in the past about how to go about in the OP and how to go about in the OT. See, a lot of this were literatures and uh, presentations on PPTs. So, but what we were thinking from the RIG team was, so rather than talking about the literature and didactic lectures, what does the institute do? What does Shankar, and the two premier institutes in the state is Shankar Nethralaya and Arvind Eye Care. So we were just thinking, let us see what they are doing in their premises. So that will set us a idea or precedence about what we can do in a private practice. It's not easy to translate whatever the institute does to the private practice, but whatever is good thing, what is possible, we can always try to implement into our private practice. So that is the reason we planned this webinar based on the current practice guidelines during the COVID in OT and OPD. And there was a lot of inquest into what does ophthalmology mean. So it was just a random thought. We were thinking what we can name this as. So we just thought ophthalmology is nothing but optimism in ophthalmology. This is the time all of us have to be positive with thoughts, but negative with COVID. So that is the reason we just coined this word ophthalmology. It's a random thought. And with those few words, and now what I would like to introduce the panelists. We have a panelist. We designed the panelists in such a way that we have a list of private practitioners and a list of corporate. So the private practitioners here is we have Sriram Gopal, Koshal, and then Dr. Vasumati. And then the corporate side, people are going to what they are doing from their end. So we have Dr. Preeti, and then we have Krishnamurthy, and then Shreyas Ramamurthy. So these three people will be representing from the corporate angle about what they do in their hospital setups. So that's the reason we planned the panelists in such a way. And most of the panelists, I'm sure most of you would be aware. Dr. Krishnamurthy is from Bangalore. They have the Prabha Eye Clinic. It's a second or third generation, I'm not sure, second or third generation of ophthalmologists, and they do have a Vitala Eye Institute, which is like a corporate hospital. They do a lot of work on it. And then we have Koshal Ram. Koshal Ram is in Coimbatore. They have recently have renovated and moved into a bigger setup. And Dr. Koshal is a VR surgeon, and his father is also an ophthalmologist. His wife is an anterior segment surgeon. And third, we have Sriram Gopal. Everyone knows about him. He's from Trichy. He has the Acura Retinal Center, and his father was an ophthalmologist, and sister as well was an ophthalmologist. And we have Vasumati Vedantam. She is from Chennai. She is from Radhatri Nethralaya. She's a VR surgeon, and the husband is an anterior segment surgeon as well. And then we have whom I left. Shreyas Ramurthy. Everyone knows about him. He is from the Eye Foundation, Coimbatore, and he's a young dynamic surgeon, anterior segment surgeon basically. But we thought the theater setup or the OPD, we don't have much difference between either an anterior or posterior, except some few differences in the posterior segment in theater and OPD. So we thought we'll get in Shreyas also for his inputs. And with this, I'll pass on the mic to Rajiv to introduce to the speakers.
Preeti also.
I forgot. Sorry, sir. Preeti is from Agarwal's, and she is responsible for this, the framing the rules and guidelines for the Agarwal network. So I thought that will also be a good one to have Preeti also on board. And she is from Chennai. She is with Anna Nagar Agarwal's. Sorry, Preeti, about it. And Rajiv, over to you to introduce the speakers and keep the ball rolling.
Thanks, Kasi. So when we were discussing about this webinar, the initial thought came that there were series of webinars on what we should do in OPD and OT, mainly about the PPE, the protection, overall trying to look at how to reduce aerosol spread. But we have evolved from there, and now there are every few days there is a new set of problems we all are facing in outpatient as well as in the OT. So we thought that having group discussing about these problems would be very appropriate. It's my pleasure to introduce Dr. Girish Rao. He's a senior vitreoretinal surgeon at Shankar Nethralaya, who's also president of Medical Research Foundation. And last couple of months have been very challenging for him. Because dealing staff of nearly about 2,500 people and varied specialities. I think hats off the way it has been managed till now. And he will be sharing the outpatient protocols at Shankar Nethralaya. We also have Dr. Anand Rajendran, the dynamic vitreoretinal surgeon from the Arvind Eye Care System in Chennai, who knows in and out of Arvind system, all the hospitals. And he'll be sharing with us the OT protocols, what they are following. Over to Girish.
So at the outset, I'd like to thank RIG, Kasi, Rajiv, and Intas for this kind invitation. And Kasi at the very outset told me that this should be only images and videos, if possible, of whatever is being done. He doesn't want any theory. So I have put in a lot of images, and I hope I'll be able to convey what we are doing at SN. But first of all, a very happy Guru Purnima to all the teachers who have joined in, and special pranams to Dr. Badrinath and a host of other legends, both at Shankar Nethralaya, Arvind, LVP, and across at the AIUS, who have been guiding us through this pandemic and over the years. So, as Kasi said, we have gone through various phases, especially in Chennai, where during the first and two lockdowns, it was very strict and we had only emergency services going on. As the norms eased up, in May, we moved on to lockdown 3 and 4, and the services improved to about 33% staff. And we also eased our surgery protocols and started doing elective surgeries for patients who were willing. And then came the unlock 1 in June, where we further scaled up to 50%, and we also opened up other centers which were closed. But unfortunately, Chennai saw a recent spike from mid-June, and that's why we again scaled back to 33%. But this lockdown has been almost similar to the April lockdown, where there was a severe restriction on travel, not only for the patients, but even for the staff. And hopefully from tomorrow, when we go on to the unlock 2, we will gradually scale up to 50%. And as the travel restrictions ease, both inter-district, intra-district, and interstate, we might have more patient flows coming to the centers. So with that background, we understood that the staff, as well as the patients, were very concerned about what exactly is happening within the state, within the city, within their locality, at home, at hospital. And we try to ease some of their concerns by keeping in touch with them through regular mailers and through Facebook updates about the do's and don'ts and what exactly they need to do when they are in the hospital premises in terms of social distancing, mask, the use of stairs, and to restrict any confined space, whether it's an elevator or a room, so that so it was very important to unlearn some of the things that we were doing, which we took it as normal, and to make them understand that the new normal is a little different. We also encouraged quite a bit of our staff who need not be in the hospital to work from home, especially the IT, the finance, the HR, and many other such non-clinical or non-medical departments, to really scale down so that we ensure some amount of decongestion in the centers. And obviously, we also needed to inform our staff that once they get back home, it's very important, because anyone stepping out of home becomes a potential candidate for getting infected And even though asymptomatic, they might carry this virus back home to their kids, elderly people at home. And so there was a lot of mailers and educational material which was shared with the staff about what exactly they need to do once they're back home. The protocols as far as hand sanitization, and the image that you see is actually a drawing which has been done by a son of one of our consultants, beautifully illustrating the social distancing as well as the correct way of using the face mask. For a 8th standard student, the understanding is quite significant. And so similarly, as I said, these kind of posters have been put up across the system, on our intranet, on the Facebook, so that the staff as well as patients are educated. And even trivial pink eye, we needed to inform the staff, the patients, as well as the staff, that it could be a presenting sign of a COVID and not to be taken lightly. And that's when we modified one of our rooms in the hospital to a permanent COVID room. So I think it's obligatory that any patient who walks into the hospital, especially at a tertiary referral center, that we cannot refuse the patient, even if he's a known COVID positive or a high-risk contact. So we had this dedicated room where we have the PPE kits, the hazmat suits ready. So the emergency doctor or the emergency consultant wears that, and then there is only the patient and the consultant in this room, and try to do a quick examination, use as much as investigations possible so that the patient doesn't spend a lot of time for dilatation and other things. But we were very clear that once the patient has had a diagnosis, we would only medically treat them. We will not do any surgical interventions for such patients because we do not have the negative pressure operation theater set up. So we were very clear that any patient who comes in as a COVID positive known patient, for any surgical intervention, we will refer him to a designated COVID hospital. But fortunately, in the last 100 days, we have not had any known COVID patient walk through our doors. And we have also tried to encourage the patients to help out in the pandemic, especially with the migrant issues that were there. And more importantly, we try to educate the patients not to use N95 masks, because that's an overkill for most of the general public. So they can restrict themselves to just a cloth mask or a surgical mask and leave the N95 for the healthcare workers. So any patient who walks in, any staff who walks into the hospital, whether on a two-wheeler or in the car, has the temperature check done right at the entrance, so that despite the advisory, sometimes we do find that the patient may have mild, the staff might have a mild temperature and not realize it. And it's very important to pick this up so that right at the entrance, these staff can be then counseled to go back home and self-quarantine for 10 to 15 days, depending on the situation. So staff, as soon as they come, they hand sanitize, mark their attendance, an advisory of absolutely going frugal. So no bangles and no rings, no watches. Come with as minimum gadgets as possible. All the staff are given a fresh 3-ply surgical mask as soon as they enter the hospital, and they're needed to wear that throughout the day. And we have an outdoor inquiry. Outdoor is always preferable, so that the aerosols, whatever are generated, can dissipate, and there is no risk of spread there. And our team at the inquiry consists of the security, the receptionist, the nursing staff, as well as an optometrist who do the triaging right at the entrance, and social distancing is maintained at all times. The staff always, in addition to the surgical mask, wear a face shield also. And these patients then, whether it's a child or an adult, are masked irrespective. And children do cooperate to wearing the mask, except if really infants, where it becomes a challenge because of the size of the mask itself. And a COVID questionnaire is filled by the patient. Now, this COVID questionnaire has undergone repeated modifications due to new symptoms being added and due to changes in the government directives itself. So the patient signs it so that we are absolutely sure that there is nothing being hidden by the patient as far as the COVID positivity or a high-risk contact is concerned. And of late, patients who are traveling from outstation, we have also included a questionnaire about whether they have had a COVID test. So sometimes when they come to the airport or the station, they do have this COVID test done, and the results are awaited when they actually come to the hospital. The patient is then directed into the main campus, and there again, most of these security staff, in addition to the mask, also have the face shields, and a social distancing is maintained during the waiting time in the outpatient departments. Again, everyone is compulsorily masked, and there is a frequent education that's going on how exactly to wear the mask, not to touch the surfaces, not to let it hang, because the people have the tendency to remove the mask and speak. They feel that they are not really clearly audible, and we need to keep counseling them. At any counter where there is a prolonged contact time, we have also these kind of glass partitions so that we protect both the staff as well as the patient. And one of the key take-home instructions that we gave to all our staff was to restrict contact time with the patient to less than 15 minutes. And I think this is very, if there is one single point, if I need to convey during this presentation, it is this, that at any point, try and keep the contact time one-on-one with the patient to less than 15 minutes. And this is the SOP, the directive from the ICMR, from the Ministry of Health and Family Welfare, which clearly defines what is a high-risk exposure and a low-risk exposure. So some of the key points at this is that at the time of exposure, the duration, whether it's more than 15 minutes, and whether the healthcare worker involved was wearing the proper designated PPE or not. If there is a breach in this, only then it is considered as a high-risk exposure. And a high-risk exposure in a healthcare worker would entail a quarantine for 7 days, or if there are any symptoms developing. All others are considered as a low risk and there is no need for quarantine. They just need to keep a close watch on their health. And in case they do develop any symptoms, they need to escalate it so that a contact tracing is initiated and the other at-risk people are also kind of quarantined. Otherwise, just talking to a COVID patient with a full PPE is not considered a high-risk exposure and does not require a quarantine. So we also then had a lot of debate regarding the HCQ prophylaxis, and again the guidelines from the ICMR, which initially said that this needs to be taken with for the healthcare workers who are in the COVID care facility or the COVID hospitals. But now they have expanded it to include even the non-COVID hospitals, the healthcare workers in non-COVID hospitals, as well as all the other essential people who are at risk. This HCQ prophylaxis in the dose of 400 milligrams twice a day for the first day, followed by once a week for 7 weeks in case of healthcare workers, and for 3 weeks in case of asymptomatic high-risk contacts at home. Now, we at Shankar Nethralaya have not included this as a part of our SOP as yet. So we have an expert, we have Dr. Ram Gopal Krishnan from Apollo, who is an infectious disease specialist, and he is our expert advisor on COVID. So he is of the opinion that this really doesn't work and there is no need, and especially in an ophthalmology setup, this risk is very, very low. So it's not worth taking this. So as of now, we have not yet included this as a part of a SOP, but as you know, with these dynamic changes that's happened, we might include it at any further time if the advisory changes. Now, the patient then moves on to the optometrist clinic, and general standard instructions is all doors should be open. This is the dressing that we have now for the consultants, the residents, and the doctors. Everyone wears a scrub, a surgical mask, cap, and a face shield at all times. Gloves is optional here because what we have felt is that gloves sometimes give a false sense of security. So people do not hand sanitize when they have the gloves, and they touch all the surfaces. At the same time, disposing of gloves by each and every healthcare worker for every patient becomes a huge cost burden. So what we have said is that the gloves should be used only if people are allergic to frequent hand washes or sanitizers, or if you are doing any procedure which is where you come in contact with the body fluids. That's where the gloves are mandated. Initially, we also had these kind of surgical gowns for all our staff, but over the period now we have eased it and we are restricting it only to certain areas. As I said, whenever the optometrist logs on to the system, he first gets a COVID questionnaire that needs to be filled. I think it's very mandatory. Just a word about the COVID consent. Now, I recently attended a webinar by AIOS on medical legal aspects, and the legal experts clearly said that there is no need for a special COVID consent to be taken, because during a pandemic, every citizen knows that the moment he steps out of his house, he is at a risk of developing or contracting the COVID virus, and it can be from any source. So there is no way to prove that this COVID source was from the hospital itself. So it's not required, but we are still continuing it for extra precaution. But really, if somebody doesn't want to take it, you are not entirely wrong in not doing it. We have modified our electronic medical records in such a way that a patient now can remotely fill the registration form and make the payments through their tabs, and in a way reduce the waiting time when he comes into our hospital and tries to get into our system. We have also initiated an online history, so the patient can actually fill his history on a set format, and as soon as the patient registers into our system, this history gets integrated to the optometrist workup sheet. And the other thing that we also actively push for now is a non-mediatic fundus photograph, especially in the non-retina OPDs, so as to reduce the waiting time. So these are some of the images where how the optometrist tries to maintain a social distancing as far as possible, and does the vision check. Obviously, what we also try to encourage our optometrists is to take history over the phone. So either through the patient's mobile or landline, so that the patient is not inside the room. Inside the room, there is as less talking as possible, and it's only examination that's done. Again, for an optometrist, they are given the option of doing an over refraction or an auto refraction, and not exactly spend a lot of time doing the manual refractions. Any special testings are deferred to a later date if possible. Again, the near vision check, patient is encouraged not to touch any other surfaces. So as much as possible, everything is done by the optometrist himself or herself. And at the again, these are pretty much the standard slit lamp measures with the face shield and the breath shield in place. And at the end of it, all of this is cleaned with 1% Virkon. We do not use sodium hypochlorite due to the relative corrosive effect on metals, and we didn't want too many chemicals in the clinics. So we have restricted it to either 1% Virkon or Bacillus, and they use accordingly. And for the glaucoma department, we have also given them a petri dish with these kind of openings. So in between, and they are provided with 2 or 3 ET heads. So they use it alternately, and this gives enough time for the ET to be sterilized in contact with the disinfectant. Now, our main target is to reduce patient waiting time, and one of the main ways to do it is to have a tailor-made workup for each patient. So if you are able to actually go through your patient registered list, and if the patient is an old patient whom you know about, you can modify his workup, the checkup, based on the presenting symptoms and when he was last seen. So for a retina patient who was just seen a month back, you might need not do a full dilatation. It could be just specific to what exactly is his symptom. As I said, the use of non-metastatic fundus camera, especially in the non-retina OPD. We have tried to reduce the investigations to the absolute essentials. So if our protocol said that every monthly OCT or fundus photo needed to be done, now it's done only if there is an indication that it's essential in terms of either the vision or the fundus changes which mandate that investigation. We have also tried to reduce cross consultation. So one of the advantages of being in this tertiary setup is that we have colleagues from all specialty, and we just try to give the benefit of the best practices to the patient and refer him to maybe a glaucoma, retina, a pediatric opinion. But now we do that only if it's absolutely mandatory. Otherwise, we in addition to our specialty, also become general ophthalmologists and do take the responsibility of these patients. We try and encourage the patients to defer elective surgeries. So we are not actively trying to push for these elective surgeries, but we have also realized that given 100 days now, there are some patients who are visually hampered, and there is probably a need for us to move on. And so elective surgery is done, especially where the patient is visually hampered. In terms of the OT, we try to reduce the time by calling the patients only for surgery on the day of surgery. So most of our surgeries now have become purely daycare. And even during the daycare, we try and call them at a staggered time. Instead of a blanket 7 o'clock arrival, we try and stagger it so that there is no crowding at the wards and the nursing station. As far as possible, give individual rooms, even if the patient has not opted for such a package, so that there is some type of isolation there. And in the post-operative, we have now shifted mainly to telecounseling. So especially for injections and minor procedures, we do not call them the next day and do the telecounseling and just check if they are fine. So that's some of the ways that we have done. Coming on to specialty OPDs, something that is done is for the glaucoma department, all the ATs and gonioscopy is done by the consultant and not by the optometrist, as was our normal practice. In cornea, maybe a dry eye assessment would not entail putting a Shermer strip, and we would probably rely more on the non-contact instruments. In the VR also, especially the pediatric patients, they are directly shifted to the consultant who decides about the dilatation and other things, rather than an optometry workup, a detailed checkup. So all these measures, similarly with pediatric ophthalmology, we try and use the parents as much as possible so that there is no touch to the patient. So whether it's for checking the binocularity or in terms of blocking one eye for vision checking, everything. So as far as possible, if the patient is 6X, we try and defer refraction. And if it's a planned cycloplegic refraction, then there is no need for doing an undilated refraction, and the subjective acceptance is deferred. So all these minor changes so as to speed up the workup within the system. For the contact lens clinic, there is nothing special. Various organizations and societies have come forward stating that use of contact lens during this COVID time is not a real contraindication, and patients do need to follow the same hand hygiene protocols while using the contact lens, and especially if they are symptomatic, it's probably prudent to defer the contact lens use for that period. So again, as I said, the modification is now we have this non-disposable gowns which are worn by optometrists at investigative centers. So at the time of investigation, we assume that the contact time is probably going to be more than even 15 minutes. So we try to give them extra protection. And at the end of the test, each of the surfaces are sanitized with surface disinfectants, either a bacillocide or a Vircon. Now, other thing that on our system that we do is previously the patient used to carry a sheet when he went from one counter to the other. Now we have withdrawn that sheet. So patient is electronically transferred from one department to the other, and whenever he visits the consultant's secretary, the secretary also is wearing the appropriate PPE, and there is absolutely minimal, if at all, any exchange of material between the patient and the staff. Now, at the consultant chamber, we allow only the patient inside. The patient's attendant generally stands at the door. So, at the either if there is a need for a history validation or a discussion of the treatment protocol, it's done so as to maintain the social distancing. The fundus examination, wherever it's done, is always done with the indirect ophthalmoscope, which has the protective film. So the consultant removes the face shield and wears this, and as soon as this examination is over, they again wear the face shield, and only then start the discussion as far as the diagnosis, the treatment. As I said, investigations are to the minimum possible, but we can't deny some of the patients requiring an OCT or a fundus camera, and wherever possible, we have tried to build this kind of acrylic barrier across the system so that there is some kind of breath shield, because these are situations which require a prolonged contact time with the patient, especially if it's an angiography or an OCT where the images are not very clear and or both eyes, so it needs some amount of time spent. Similarly, for an ultrasonography, this is kind of the PPE that we do. For the laser, our emphasis is more towards LIO, laser delivery system. We try and avoid slit lamp until if it's absolutely mandatory, depending on the diagnosis, the prevailing condition. Something that I must compliment our maintenance team is we have developed this in-house unit of UVC disinfection, and UVC has been shown to be very effective in disinfecting any surface depending on the specification of the instrument. So anywhere between 300 to 600 square feet of area is disinfected on an exposure of about 20 minutes. So this can be used very effectively for sterilizing the outpatient rooms and the clinics at the end of the day. The only caveat here is that at the time of the actual UV exposure that's going on, there should be no human presence in that room. So that's absolutely mandatory. So you devise an equipment which gives you enough time to exit the room after the instrument is switched on, and it auto switches off, so that you can, the same instrument can be used at multiple locations, and you can sanitize the place over the night and keep the place ready for the patients for the next day. Now, in terms of surgery, we have obviously have not changed our protocol about no bilaterally simultaneous surgeries unless the health condition and the GA mandates that repeated GA may be an issue. So it's sometimes in infants and neonates, we might do a lensectomy bilaterally, but as far as possible, as an institutional protocol, we have not moved towards bilateral simultaneous surgery to reduce the patient's visit during this COVID time. For the oculoplasty, most of the surgeries are still not being taken up because they are aerosol generating procedures. But in due course, we will do that we will take this up with due changes in our PPE protocols as well as COVID testing. We do not do bilateral intravitreal injections, so we still maintain a gap of 3 to 4 days between the injections. But as I said, we have relaxations in our post-op follow-ups, and we have used telecounseling quite a bit in reducing the patient's visit in post-operative period. Now, initially, COVID test, we never had it as a mandatory because it was never a mandate. And with the changing government directives, it was becoming increasingly difficult to do these tests. Even now, the present guidelines suggest that if a COVID test is done, the patient actually needs to quarantine till the report comes. And in West Bengal, the mandate was the patient has to be admitted as an inpatient and only then a COVID test will be done. So for all that reasons, we actually did not go ahead with the COVID test, but now we have modified it because of the growing number of infections within Chennai, and though it's not official, there is a suspicion that there could be a community spread in the society. So we have made COVID now mandatory for GA, but that will not deter an emergency surgery from being taken up, because COVID test does take 24 to 48 hours, and we won't defer an emergency surgery in case it needs to be done as soon as possible. For all other cases, a COVID test would be based purely on risk analysis, and that decision is taken by the physician. Now, briefly, I'll just go on to the OD protocols, though Anand will be doing it in much greater details. And the mode of transmission is basically through droplets and airborne. And droplets is something which occurs with cough and sneeze, and it can go to well beyond 2 meters. And the droplet sizes are also bigger. Whereas an airborne is something that happens as you're speaking or as a part of an aerosol generating procedure. And these are much smaller in size, but they tend to remain in the air much longer as compared to a droplet, which tends to settle down. So both are at risk and both require certain protocol changes. Now, in an ophthalmic setup, the aerosol generating procedures, which are of significance, are obviously the oculoplastic surgeries because of the drilling and other things involved, as well as LASIK. And more importantly, it is with all GA related procedures, whether it's intubation, extubation, the suction, nebulization, or even a CPR for a code blue. All these are aerosol generating procedures and need to be done with caution. So obviously, there is a leaning towards topical or a regional anesthesia as compared to general anesthesia, for the obvious reasons that there is no airway instrumentation, so you're not dealing with some of the known sources of viral spread, and consequently the patient's stay in the hospital is reduced, whereas GA obviously requires a lot of pre-op, intra-op and post-operative monitoring and would not be an ideal choice. So our PPE for all the doctors, whether it's doctors, the nursing staff or the OT assistants, is the same irrespective. So they, over the scrubs, they wear the surgical gown, they have a cap, leggings, gloves, an N95 mask, the face shields and face shields or goggles. So some of the surgeons would use goggles, whereas the anesthetists, the nurse and those who do not look through the microscope, they would be using the face shields. For the N95 mask, we follow the AIMS protocol, where we give all our staff a set of 4 N95 masks, and they use it every 5th day for 5 cycles. So at the end of that, this is discarded and we replace it. So in between, they just place this in a clean paper envelope and keep it away in a dry place. Obvious precautions of not touching the inside or the outside surface of this N95 mask. Whereas in the OPD, it's only the surgical mask that our staff uses. And another protocol that we have added is a betadine gargle to be done 15 minutes before surgery. So betadine 2% goggles is available, and we have 1 bottle per patient. So the patient takes that bottle back home and continues this gargle twice a day in the post-operative period also. all patients wear surgical masks throughout the surgery, and we have tried to reduce their time within the OT by shifting them directly from the ward to the operation theatre and not to the waiting area or the ICU. So all these are done to reduce the waiting time. We also have tried to use this aerosol box, which was initially designed only for GA cases, but you can easily give the local blocks also by fashioning these openings both on the front and the sides. So it's possible to do this procedure this way. And after the surgery, again, all touch points, everything is sanitized. So actually, we spend more time in between the cases than during the case. During the case, before the patient comes in, a clear instruction is given to all the staff about the equipment, the drugs, and implants that are required, so that during the surgery there is minimal movement in and out. It's a quick in, quick out kind of procedure. But we spend a lot of time in between cases in terms of getting the whole place sanitized, all the surfaces, before the next patient is wheeled in. And of late, we have also moved to this gadget, which has been fashioned by our anesthesia team. Sorry. So this is a mask which has a connector with a inspirator arm and an expirator arm. So in the inspirator arm, we have the oxygen coming in, the expirator arm, the carbon dioxide, which is, and these are monitored with non-return valves. So even in an LA, the patient actually is now breathing into this, and the aerosol, which is probably a risk despite the proper draping that we do, we have tried to reduce this further so that the patient's exhaled air does not contaminate the operation theatre. Because as I said, we do not have negative pressure theatres. So we try to modify this, and this is the image where you can see the patient. This mask is secured with tape, and though it looks like as if the patient has been intubated, it's not intubated, and the patient's monitoring is done where in addition to the oxygen saturation, you also look at the CO2 monitoring. So for our anesthesia, again, as I said, because it's a pressure negative, we have tried to make our OTs pressure neutral. So previously it was all positive pressure. So the air was vented in and it was forced out through these return air ducts. Now we are trying to make it pressure neutral so that the turbulence is less. Whatever aerosol is generated gets dissipated and it's not really agitated into the system. But we have tried to now reduce that further. So these the Boyle's apparatus have these kind of attachments which actively scavenge the exhaled air, and it's let out into the return air, so that further reducing the risk. But this kind of situation works only with GA cases. And there is we use these filters, the heat and moist exchange, quite frequently, both at the inspiratory and the expiratory limb, so further to protect our equipment, because these would be reused in between cases. So we have developed our own aerosol box, and that's being routinely used, and our anesthetists are quite comfortable now using this for all our GA cases, though there is a little bit of struggle for doing ROP intubations, because these kids are very small and sometimes it becomes a bit of a challenge for them, and in such cases they would go ahead and do it without the box. And Dr. Jayachandran has actually been recently awarded for an Innovators Award for actually converting this aerosol chamber into a adjustable negative pressure box with this tube and a so this tube has an exhaust, and all the exhaled air is actively sucked out. So this has got an award from the anesthesia body recently. So we also have these obvious donning and doffing procedures, which are our staff are counseled about. So, and there is a lot of emphasis now on actual aseptic way of doffing, so that we further minimize the risk of exposure for our staff. And Again, all the as far as possible, all the equipment are covered with cling wraps so that they can be sanitized very quickly, and there is no risk of disinfectant corroding any of the surfaces of these. Just a final few words. One of the things that we have of late seen is the use of mask by our post-operative patients. So since our protocol is wear masks, the patients do tend to wear masks even at home, and the way the masks are, it brings it, especially the nasal side of it, very close to the eyelid and the operated eye. And if the patient is not careful about touching or changing the mask, it can become a potential source of infection close to the surgical wound. So maybe it's good idea not to ask them to use the mask at home and just self-isolate in a room where they don't need this mask. And there are papers coming off some of the studies indicating that probably there is a higher risk of endophthalmitis in this COVID era. So if someone wants to use an intracameral or in the infusion, it may not be a bad idea. Or if you're doing a clear corneal incision, maybe just taking a stitch at the end of the surgery would further protect these patients. Obviously, as this webinar suggests, we have moved from classroom to online classes even for our academics. And last word on social distancing, and this is probably the biggest challenge for us, the cafeteria and the coffee shop. So we have tried to reduce the tables there, but invariably if people do go as a group, they tend to drop this mask, especially when they're drinking. So if they're drinking as well as talking, there is a potential risk. So this kind of an open air setting is fine, but if it's a cafeteria in a closed room, it is a potential source for infection spread. So finally, I take this opportunity to invite you all to this webinar planned by Rajiv on how to get funding for my research. It's a very interesting concept, especially for people who are interested in doing huge researches. And this will be on 12th of July and on 19th July, because we have an array of international speakers, experts who have been doing huge grants, who have been getting huge grants for trials across the globe. So please do join us for that. Thank you.
Rajiv, over to you.
Thanks, Girish. Really, you gave a very good overview of whatever we are doing at Shankar Nethralaya. There are a couple of questions from the audience. I will just first take them before we go to the panelist. Swapnesh had a couple of questions. I think Betadine gargle already you have covered. He had the question that SN has a centralized AC. How do you manage? There are no windows in most of the VR clinics.
Yeah, so as I said, we have tried to make it now as a pressure neutral AHU. So there is no active pumping of the air. We have tried to reduce the speed at which it works. But at the same time, it's very difficult to build windows into the system. So what we have done is we already have HEPA filters at the AHU end of our AHUs. So that protects. Plus we also have UV filters at the AHU. So this also sanitizes the air to an extent. And we have tried to increase our air exchanges. So previously, to maintain the temperature low, the air exchanges were less. So that is the same cold air which was recirculating. But now we try and do almost 20 to 25 exchanges per hour. So this, kind of dilutes the air which is circulating in the closed system. So these are some of the modifications in AHU.
Swapnesh also gives his suggestion what he does in his OPD. He tells that he uses a standing fan to direct the air currents away from the healthcare worker in his clinic.
Yeah,
so that's one of the things which he does.
I saw some of the photographs, but I think if I were a patient, I would not be very happy with my doctor, because it's moving the virus load from a healthcare worker to me directly. Let it be equal for everyone. Why expose myself more? So I would be not happy with that kind of setting.
He also gives a suggestion of a micropore tape to the surgical ply mask
That's
for
a suggestion. Yeah.
for patients and even non-clinical staff.
Yes,
that
that's
can
a very
be
good
added.
suggestion. Yes,
Yeah.
especially when we are doing the slit lamp biomicroscopy or an indirect ophthalmoscopy, it does tend to fall. It's a good suggestion, and
Yeah.
it would actually stop the patients from dropping the mask at the drop of the hat kind of situation.
He had some questions about pre-op testing. RT-PCR already you have covered, and chest X-ray CRP for retina patients, because he said that gynecology people and orthopedic surgeons are doing it. What is done at SN?
So before we did COVID as a mandate for our GA patients, we did have a protocol of doing X-ray chest for all GA patients. Previously, we used to do that only for 40 plus, but now we do it for all. But ever since the COVID test has come, now we have stopped X-ray as a mandate. Though there are centers which suggest doing a HRCT is more sensitive in picking up lesions, but we have not yet made that as a part of our SOP.
Sure. About positive pressure already you have covered, but he has that what PP gear is donned by the retina surgeon and retina assistant, OT assistant at SN.
So I think whatever I said, it's uniform, whether it's retina, anterior segment, the nurse or the staff. We treat them at par, and everyone, whatever image I showed you, the N95 mask, the face shield, or a goggle, the gloves, the surgical gown, foot cover, cap, that's mandated for all staff.
Anand, anyway, you'll be covering that, but just a quick question, the same question to you, what you are doing.
Yeah, so I'll be covering that a bit in my presentation. So what you'll see is where we've made a slight difference with retina OT and personnel compared to cataract, because retina surgery is it's all about the viral load and exposure. So in retinal surgeries go up to 1.5 hours as compared to say a cataract surgery which might just be about 10 minutes or around about that. So keeping that in mind, my staff have been asked them to wear a coverall, and I'll be showing pictures of that later. And over that, green gown. So if you're doing more than one surgery, what happens is, as you'll see in those pictures, that the green gown over that is removed, okay, and the coverall remains. So that is there. That's one difference which is there. And I think amongst ophthalmic procedures, as Dr. Girish also highlighted, I mean, oculoplasty surgery is definitely, but I think retinal surgery is also one needs to keep in mind the fact that you're going to be exposed to sometimes even 1.5 to 2 hours. And given that all these other paraphernalia is coming on to the staff, that, I mean, a normal surgery, if it says 1 hour, you'll have to add an additional 10% of time to the procedure for any procedure. So given that fact, I asked my staff at our center especially to wear a coverall underneath, and I'll show you pictures about that. Otherwise, more or less the same as Dr. Girish.
I think we'll have some questions to our panelists before we go to the next round. Kasi, would you start?
Yeah. So welcome, Dr. Vasumati, a little late, but you are the opening batsman for the panelist. Still, you get the privilege of it. I think you have to unmute, Dr. Vasumati. Yeah, that's fine. Yeah. So first we'll start with Dr. Vasumati. So regarding the OPD, since we had the OPD discussion, so if one of your staff becomes positive, so what steps will you follow?
If the staff becomes positive, of course, we will ask the staff to first stop coming for work, find out what has happened to the rest of his or her family, whether they have been tested, whether it's a mild COVID or moderate to severe COVID, and what's happening to the staff and the family. And as of now, I really haven't thought about doing the test for other of my asymptomatic co-workers. Of course, we would tell them to watch out for all symptoms of COVID. And here at Radhatri, every day we have a protocol of monitoring the temperature of all the staff, including myself and Dr. Praveen, when we enter the OPD. So any fever or cough or myalgia, any staff who has come in contact with a positive staff reports any of that, they have to inform us prior and not come for work that day, and get themselves self-isolated first at home. And if the symptoms increase, we would encourage the staff to go in for COVID testing. Otherwise, as of now, if the asymptomatic contacts of the positive staff, I mean, they're still asymptomatic, I would not insist on testing for all the rest of the staff members.
Same thing we'll ask Dr. Shreyas. What about you? Because you from the corporate side.
So we have a slightly different system. We have a shift basis by which staff are coming. So far, we haven't had the challenge of having a positive staff. So because Coimbatore, only now the cases are increasing. But the protocol we have in mind is that if a staff becomes positive, the contacts and the surrounding of that department, that staff who are in exposure with them, will all be asked to stay back, all of them will have to be tested. And probably even despite a test, as we all know, the incubation period can last at least 2 weeks, and they will be asked not to come for 2 weeks. We have a backup as they are coming on rotation. The backup team will have to continue. Now, if one member from each team gets infected, that is definitely going to be a challenge, and we'll have to reorient certain things accordingly. We've also tried among our staff, since a large number are staying in certain in our own hostels and dormitories. We've tried to separate the hostels, dormitories to increase spacing. I think the same is being done in Arvind as well, so that the amount of contact, even the time when they go for lunch and dinner, has been regulated to the extent possible. I will not say it's perfect. Definitely, these young girls do not necessarily immediately respond or understand the seriousness all the time. But to the extent possible, they have been separated, so that even if one person comes in contact with the COVID positive patient, the others are not necessarily at risk.
So you mean to say that the entire team will be quarantined?
At least the team which is, yes, the immediate, like the regular contact tracing, which the government is doing even for a regular positive patient outside. So we would do the same contact tracing technique within our own hospital of that particular staff, the limited circle of people who they are coming in contact with. So if you, for example, our own retina department, be it if a sister comes in contact, then the associated single counselor, the associated consultant, the associated investigation staff, they would all possibly have to stay back. And the other set of counselors, investigation staff, and doctors who are alternating with them will have to come full time.
And you do RT-PCR for them, or you just quarantine them?
We are doing. Our aim is to do RT-PCR. We've even done RT-PCR for some of the staff who've come back after the lockdown from red zones, which was actually the protocol being followed in the Western districts at that point of time, Western districts of Tamil Nadu at that point of time. So we have already tested some of them, and we would continue to do RT-PCR.
Anand, what you will at Arvind, what you have planned when you get a positive patient, positive staff?
Yeah, so actually we did have 2 positive staff in our setup just a few weeks back. So I was about to drop the bombshell on you guys. But so what happened was these 2 were taken to a dedicated center, and they were kept there for a week. And they just had 2 or 3 days of very high fever. After that, they kind of improved, and the subsequent test was negative. And then the entire team around, like as Shreya said, the team around that, we have an active system of contact tracing amongst their colleagues and people whom they're working with. And I think Dr. Girish also showed that one particular slide about high risk exposure and low risk exposure. So all the contacts were deemed to be low risk exposure. In a nutshell, high risk exposure amongst healthcare workers is when when the particular contact is not wearing the adequate prescribed PP. So while that was maintained, so in any case, about a dozen two sisters were quarantined. We call the MLOPs, or known as sisters, were quarantined on a separate segment, a wing, pre-dedicated for this kind of an exigency. And unfortunately, they have come out of that quarantine. So about 2 weeks, 2.5 weeks since. But we are still keeping those two sisters. They were discharged after 1 week from the dedicated center, and they're kept in isolation. Fortunately, we have a in-house physician who's staying on campus in a part of the wing. And so those healthcare workers are monitoring them, and they're doing fine.
That is fine, but I was only wondering that what happens to a private practitioner?
Yes, can I add something?
Please. That's what the view I wanted.
The question is actually, if one of our staff becomes positive, would you be doing RT-PCR for the other staff? At the present point of time, the answer to the question is basically driven by the government. As a private practitioner, especially,
exactly.
If you order RT-PCR for an asymptomatic staff, then the asymptomatic staff, irrespective of the result, is going to be quarantined. And already we are struggling with about 10 to 20% of the staff, and the rest of the staff are locked up elsewhere in their hometown. So we have to be practical. So the key thing is, if the other staff are asymptomatic, there is no fever, there is no cough, they are fine, then we just pray to God and go ahead. And tell them to be on the watch out for any symptoms of COVID, monitor their temperature. And also here at Radhatri, we keep doing the pulse oximetry also to rule out the happy hypoxia and all that. So that is I think that's the practical way to go forward. We really cannot afford to quarantine or self-isolate the other asymptomatic staff who might have come in contact with the positive staff. Now, of course, at present, thankfully, all these are hypothetical scenarios. But if a staff, God forbid, but if a staff turns out to be positive, this is the way I would be dealing with the situation.
Dr. Girish, you wanted to add something?
Sriram,
Kasi, I want to say something.
Yeah, Sriram. Go ahead, then we'll ask Dr. Girish.
Kasi, two things. First is, there is a difference between one of our patients who walks in testing positive and one of our staff testing positive.
So we have a separate question on that. Now we'll stick to staff.
No, why I'm saying that is, when it is patients, generally you're protected. When you meet patients, you're protected. The problem with the staff testing positive is they always let their guard down when they go to have a break, when they go to have lunch. They don't wear their mask, they stand next to each other, they talk. How much ever you tell them, they are scared of patients. Whenever they come to the patient area, they will all the protection. But between themselves, they don't think they need protection. So there's a lot of difference between that and this, first thing. Second thing, the size of the hospital. You can always say you can isolate that team. But if it's a small hospital with total 20 employees, they are going to intermingle. How will you isolate that team? It's just one team. Third thing, you cannot say that, I don't know, you can speak for yourself, but in Chennai, maybe if you test PCR, you have to isolate them, but I don't think it applies to the rest of the country or the rest of the state itself.
Yes.
In Trichy, you can very well do a PCR and not isolate a patient. I do PCR for all my pre-op patients also. So it's not necessary to isolate. And if one staff tests positive, the other staff are primary contacts. They are very high risk. And according to government protocol, you have to do PCR for them. Even if you don't do, the government guy is going to come catch them and do PCR and then quarantine them.
Sriram, let's leave the government protocol. What do you do in your place?
If one of my staff tests positive, I will quarantine the rest of the staff, and I will do, I don't have any option but do PCR. Even if I don't do, the government will do. That's what I'm trying to tell you.
Correct.
Okay.
You don't have a choice of doing or not doing PCR.
Chennai, they don't even asymptomatic household contacts of positive patients is not doing. That's the reality.
I understand. That is because Chennai is overwhelmed with cases. And letting the staff continue to work without a negative PCR or without a quarantine actually puts your other patients whom they see day in and day out at risk. So even if you don't do a PCR, you at least need to quarantine the primary contacts of that positive staff, which in a small establishment basically means everybody.
Yes, sir. And at this point of time, it's not challenging to get a COVID test done, at least here. So we have NABL accredited labs right across the road where any patient can walk in and get a COVID test done with just a prescription from the doctor. So it's very easy for us, at least at this point of time, to get a test done.
Now we have changed the protocol in Tamil Nadu as Chennai and rest of Chennai.
Yeah.
Yeah.
It's always rest of Tamil Nadu versus Chennai.
Yes,
Tamil Nadu versus Chennai.
Yes, Kasi, I think Sriram said the entire team has to be quarantined. And as Shreyas said, I was discussing with the corporation officials in the meeting last week, and they said, and it's very easy to undergo a PCR. You can just have to submit an Aadhaar card, and the rest thing will be taken care. So I think the entire team has to be quarantined for a particular period of at least 2 weeks, and then before they can come back to
So
work.
now they size down the quarantine for 7 days.
1 week.
7 days.
do a
If you're asymptomatic and
do
end
a-
of after 5 days, basically 5 days from contact, you do a PCR, and up to 7 days you're asymptomatic, and on the 7th day you have a negative CT test, you can go back to work.
So, a last word on this by Dr. Girisha. You want to add on anything, sir?
Yeah, so the only comment I had was regarding the testing. So we are talking about RT-PCR, but ICMR has modified its guideline and said that for healthcare workers who are at risk of exposure, you could do a COVID antibody testing. That's a quick way of doing a surveillance, serosurveillance, and only if it's positive, you do an RT-PCR. So you need not do an RT-PCR, which is costly, more time consuming, whereas antibody testing is only 30 minutes. You get it, and only if the high-risk contacts that you suspect would have had exposure, and if they show positive, then you can go ahead with the quarantine or RT-PCR testing. So,
But that's a surveillance only, no, sir.
Yes,
The
sir.
antibody test is only a surveillance and not for diagnostic. No?
yeah, but
See,
so
I just
if it becomes positive,
Yeah,
so you
Anand.
can,
And if
especially
it
in
touches
a,
the good, I would be happy actually. I'll feel protected.
Yeah, all of us.
Yeah, so I would rather.
The sensitivity of an
Have
antibody test is very poor. That is a problem.
yes.
Fine. One last word from Krishnamurthy, then we'll move on to the next. Krishna, you wanted to say something.
Yes, when one of your staffs come positive, actually there are some things that you can do and there's some things which you cannot do. That is where the government still takes over, like Dr. Anand as well as Sriram was saying. If somebody comes positive, this thing is that the pro is that you have to do a perfect contact tracing before it snowballs into a bigger problem within your own organization. So perfect contact tracing is important. Once you have seen the primary contacts who have been at high risk, like what Dr. Girish Rao showed, the table, the high risk contacts where you will see, if you find those, they have to be separated out and they will have to be tested for RT-PCR because that is part of the epidemiological survey. You cannot run your own course after that. You will have to test them for RT-PCR. But the way the thing comes is that once a staff comes positive, there will be a lot of panic in your system. Every patient, every worker wants to get tested now. This is where you have to draw a line and say, unnecessarily don't get tested, because you will have many of them who will come positive also there. Because you have many people who are asymptomatic and moving around. What will happen is that everybody will want to go into quarantine immediately after that. So you will have to draw a balance between riding on the guidelines of the government, which is primary contacts need to be traced and isolated. Secondly, not to create a panic within your own staff who might have remotely come in contact but want to get tested. So there you'll have to bring in the confidence to say, look, you don't need to be quarantined, you don't need to be isolated, come to work, but make sure that you are looking out for these particular symptoms. If any of these creep, immediately escalate. So I think more than the testing part is the panic that will create, because we had one of our receptionists who turned positive and she went into care and all that. But unfortunately for us, she picked it up outside the hospital. And her brother-in-law was a police inspector from where she got it. And she was on leave for about a week before she came to hospital. So we didn't have to test any of our staff. All we had to do was that we will closely watch you for 14 days, because for the last 7 days, nobody had primary contact with her. So I think it is the balance between how do you keep the morale of your workforce going, along with not violating the government regulations which are there, where if a primary contact is there, it needs to be tested.
Well said, Krishna. That the recent example in Chennai is we had recently a multi-speciality hospital, a big multi-speciality hospital shut down even the regular OPDs because there was a lot of positive in that hospital. So as you rightly said, primary testing, and then based on the region and based on the individual protocols of the particular place, you can set your guidelines.
Kasi, a small
More than-
question to Anand. Anand, you said 2 of your staff had tested positive. Did you do RT-PCR for the rest of the staff who came into contact with those 2 staff? Or you mentioned that you quarantined them. But did you do RT-PCR for the other staff?
So we went with the guidelines of that COVID hospital, and they did not mandate testing for asymptomatic primary contacts, just isolation. So that was what was the requirement there. And this is a moving goalpost, as I think many of you have mentioned. Guidelines, if you see in April and in even early May, and now in June, have moved significantly. Okay, it's changed significantly. Like I think somebody mentioned, it's gone from what was initially 3 weeks to now 7 days. 7 days, though we maintained a 15-day quarantine isolation period. And I'd just like to quote the CDC's strategy. They moved from, there are 2, symptom-based and test-based strategy. Most dedicated centers here are going by symptom-based strategies. And this is with regard to how people should move from isolation to back to work. So I'll quote it. It says, person with COVID-19 who have symptoms and are directed to care for themselves at home may discontinue isolation under the following conditions. A, at least 3 days, 72 hours have passed since recovery defined as resolution of fever without the use of fever-reducing medications and improvement in respiratory symptoms if they were there, that is cough, shortness of breath. That is A. B, at least 10 days have passed since symptoms have first appeared. So this is what is CDC as right now. Test-based strategies, previous recommendation, test-based strategy remain applicable. I mean, that's what.
That's fine. So now we'll move on to the next question.
Yeah.
This is more interesting, and I am sure a lot of people will be happy to answer this. So do you intend to increase or have increased the OPD consultation? We are talking about only the OPD, diagnostics and OPD. That's what Sriram.
Yeah, I have increased my consultation by 50%. So I don't see anything wrong in that. I am incurring much more cost than what I would otherwise. And well, there are 2 ways of going about it. I have just increased my consultation fees, and that's it. No other explanation. I don't think I need to give an explanation to increase my consultation fees. It's my right. There are some hospitals which show the original consultation fees and then add an extra fee because of COVID. Well, this has got the plus and the minus side. The plus side, you can say that you're very transparent, that you're passing on the additional cost to the patient and you're transparent about it. There have been issues also. There was one multi-specialty chain, infertility chain, where they had charged 100 rupees or something for the extra cost. And somebody had taken a picture of it and said, they gave me 2 drops of sanitizer in my hand and they're charging 100 rupees for it.
COVID fee.
So this is a double-edged sword. So, but I am charging more, and I think you can charge more. And it's my humble opinion that you need not really give an explanation of why you're charging that extra cost. Because as a practitioner, you have the right to fix a fair fee for your services.
It's across the diagnostics and procedures as well?
No, only for the consultation. Because I think it works out around 40 to 50 bucks extra for a patient, per patient. On an OPD basis, not the theatre patient. On an OPD basis, I think it works out to 40 to 50 rupees extra per patient. So I made an increase.
So how about Preeti? In your place?
The Agarwals have increased the consultation by 100 across India, sir. So wherever we usually have a different consultation fee in each tier of cities. But what has happened was we have increased flat rate of 100 in every tier. So this is about OP.
So how about procedures and diagnostics, lasers and diagnostics?
Investigations, the costs have not been escalated at all. As far as surgical thing, the tariff is not, we have not raised the tariff, but we have added on a cost saying for the personal protective equipment, we are increasing, we are having another pay.
No, we'll have the OT thing later, the OPD. We are talking only about
OPD, only consultation which has been increased. Rest everything is same.
What about Kaushal?
I've increased by 25% to cover the cost of the PPEs and stuff, and there's no complaint from the patient end, I think.
Okay. So it's all. So all of us are concurring that we have increased only the consultation fee, but not the procedures and diagnostics.
Not increased.
Yes.
So madam is not increased.
As far as the diagnostics, Kasi, on the fields, we have increased it because we give them a N95 mask to wear because we are not confident of the disinfection of the bowl where the patient is breathing when he's doing the fields exam. So it's mandatory for all our patients to wear a N95 mask and then do their fields examination. So there, the cost of the N95 is added on to the patient because either they buy it or they come with the N95 and do it. So that's an add-on cost. When we're doing FFA and ICG, at that time, our staff are doing it in PPE because that's the time when the contact time is close to 15-20 minutes across the thing. As Dr. Girish was saying, this is where the risk is higher. So they are in full PPE when they are doing the FFA, and they also likely to come in contact with blood and other things and panic at that time. And this is also a place where aerosols can be generated if the patient faints and you have to either give oxygen or things like that. At that time, you can't go looking for protection. So what we've done is that when FFA is done or ICG is done, they are in full PPE and the cost of the PPE is added on to the patient or about the FFA.
Makes sense. How about
vomiting?
As
When
far
a
as-
patient retches, when a patient retches because of the fluorescent, he will generate aerosol.
Absolutely.
Definitely.
Vomiting.
Correct.
Yeah. Preeti?
Yeah, as far as Agarwal Eye Hospital is concerned, sir, there are around 81 branches which are across India. But each of this branch actually acts as a individual branch with a specific set of investigation and other things. So in our setup also, we have given complete PPE to whoever staff we have categorized as high risk and moderate risk. So the high risk, because we have to do multitasking. We cannot have staff saying one staff will do only refraction, one staff will do FFA. If it's an optometrist, the optometrist has to take up the FFA also, has to do the refraction also. So any optometrist has been categorized as a moderate, as a high risk staff, and they have been given a set of PPE, which would include right from the gowns, which have been mentioned, through the N95 mask, shield or a goggle, and barring the shoe covers, the rest everything has been given for the high risk staff. And the staffs have been categorically divided into moderate, high risk, moderate risk, and low risk. So that's how we have divided the PPE, taking into consideration that each will be each have to do some multitasking also. We cannot wait. We cannot. The doctor cannot see that only one doctor will be seeing the red channel patients. So we will sometimes be operating with only one doctor who has to do everything. So the doctor also will be completely donned in a PPE like a coverall and will be going. So we have increased the charges like that. I'm just trying to tell that we have increased the charge, having in mind that everybody is on appropriate PPE in all the centers. So across centers, it is 100 rupees fine for consultation.
And last word from Anand and Dr. Girish Rao, sir. How about the fees has been increased, escalated?
No, we have not escalated our OP investigation or OT charges as of now.
Sir, Girish, sir.
We have increased 100 rupees for our OP because we provide surgical mask for our patients. In addition to all other patient and the attendant, every time he comes, he's given a fresh mask. So whether it's a first consultation or a review, next day follow-up, they are given new masks. So we have factored in that in addition to the other costs. And as Preeti has said, if a patient were to need a COVID protection because he's turned COVID positive, we also use hazmat suits, and that cost is then billed separately to the patient.
And a few things which things I had questions asked. The temperature settings, sir. Girish, sir. This is to Dr. Girish, sir. So the temperature, you check the temperature in the outdoor. Is there any difference when you check the temperature in the outdoor, or you're going to check when the patient enters inside the hospital premises? Because your photograph was on the outdoor.
Yeah, but it's a shaded area. Okay. And luckily, Chennai has been having a lot of cloudy weather.
Of the past 3 days.
Affected. What we have seen is, especially when our consultants drive in the car with the AC on, and then they lower the window and the temperature is checked, it does show a slightly lower reading.
Okay.
Yeah, what we do is we have encountered such things. People who come walking from outside, they record 99.5. We have kept the bar as 99. Anybody who's above 99 will have to either wait for some time. After 10 minutes, they'll again have a temperature check, and then only they'll be let inside. If the temperature check is more, then somebody will come to the triage and then discuss with the patient, and then we will decide. So this is what we do.
I think I agree with what Preeti is saying.
Bundled up with a lot of warm clothing and all that. The babies, invariably, the temperature is 99 plus. So we have to ask them to remove them and then keep them, swaddle them. Then we recheck the temperatures.
Okay.
No, what Preeti says is fair enough, because if they were walking in the sun, the temperature is going to be high. If it is high, you just ask them to wait in the shade for 5-10 minutes. And one more thing we are forgetting is all these non-contact thermometers we've used, most of them are Chinese made. So the reliability.
One more thing I have seen
all of them
this,
as of now.
As
of now.
Actually, this has to be seen at 50 millimeter to 150 millimeter distance. It has to be shot at that distance. What happens is when we say them to fire, they fire either from a very long distance, so you cannot completely relay. So I had to really go back and tell them that this is the range in which this has to be fired. Keep it between 50 millimeter and 150 millimeter and then fire and then record the temperature. You do it very far, it will give you less reading. You do it too close, it may give you.
And most of the thermals can give the same reading only.
Yeah, there was one video where you remove the sensor and you try firing it. It just keeps giving you a value between 36 and 38. It is just programmed like that. That's it. Irrespective of wherever you fire it.
So
the equipment itself is pretty dubious. On top of that, we have our climatic conditions and the way you do it and observe variability and all these things. I think this temperature testing is more of a government protocol which we need to follow, rather than something going hard and fast.
But it does pick, sir. We have picked people. It does pick.
Yeah, you can pick up people. What I'm trying to say is somebody with a normal temperature is not necessarily safe. Somebody with an abnormally raised temperature you might flag them down. But otherwise, there's nothing sacrosanct about this. That's what I'm trying to say.
Exactly.
Poor sensitivity, high
Everything has to be clinically correlated, basically. We have three things: triage question,
scanners are
temperature,
the gold standard. Thermal scanners, not infrared the testing.
And one more question before we move on to Dr. Anand. See, this mask, there's various types of masks. People even use their kerchiefs, dupattas, everything as mask. So hospital, do you have a protocol saying this is the basic minimal requirement for a mask to enter the premises?
Yeah, Agarwal has got a very strict protocol.
We'll just have one word from each. We'll move on to Anand. So
We have a very strict protocol saying they have to change over to the surgical 3-ply which we are providing. As what Dr. Agrish sir was also saying, we provide them with surgical 3-ply. It is covered in consultation for the patients, but the staffs, but the attendants have to get it extra. They have to buy it from the pharmacy and wear it. But we want them to enter only with the 3-ply which is provided at the front. So whatever they are wearing, on top of it, they have to wear, or they have to remove it and wear ours. And we also give them a sticker.
We don't definitively, but we have a stock there. If we feel somebody is wearing an inadequate mask, then they're requested to buy and use an appropriate mask.
Girish sir?
So we ask them to change if they're wearing a cloth mask. If they are wearing an N95, we ask them to continue that. But we discourage an N95 mask with an expirator. So if it has an expirator, we ask them to put a surgical mask over it. Because it's protecting them, but putting others at risk.
Yeah, you're always worried about both ends, sir. From the fan itself, we guessed it.
We ask them to put any mask over. On top of this, they have to put our surgical mask if it's a better quality mask.
Yeah, Shreyas,
we are providing a surgical 3-ply mask free of cost for both the patient and attendant. Initially, we were thinking of pharmacy, but the whole concept of patient entering the building, going into the pharmacy, buying a mask, it defeats the entire purpose. So we do the screening right at the entrance at all the hospitals, at the gate itself, and the 3-ply mask, the entire shelf with the washing area where they have to wash their hands and other things, and then wear a surgical 3-ply mask on top of it. It comes.
That's
it.
Yeah, we provide a 3-ply mask, and it's being charged at the end. And most importantly, what I do is before they enter the surgeon's consultation room, we ask our OA ophthalmic assistant to tape the mask, because that is where they start removing before the slit lamp and other things. And Sriram had a nice video in which they nicely tape.
I'll share it now.
We have given it at the triage itself. The billing happens at the pharmacy, but the triage itself, they will give the mask and the tape. We have tapes which are cut into small pieces. They'll give
I give them the mask
and the tape.
Irrespective of what they wear, I ask them to change it, because it is not easy to explain to why I let somebody in without with an N95 without a respirator, whereas I'm asking somebody else to change an N95 with a respirator. So there's no point trying to explain these to everybody coming in. So everybody who comes in, whatever they are wearing, take it off and use the mask I provide. I provide a mask for a patient and one attender. That one attender, I call him only when I finish my consultation, not when I'm seeing my patient, etc. So they wait outside, final counseling, I just call them in for 5 minutes with the mask, talk to the patient and attender. Otherwise, the patient will go outside and then the attender will want to come back and listen to my explanation. So for that reason, I just call in the attender only when I finish my consultation. And I will just share the screen. I think I have the thing. Yes, 1 second.
Yeah.
This is what Kaushal was talking about.
By the time sharing, Krishna,
Sorry.
what about you?
We follow very much like what Dr. Anand was saying. If
This
they're
one,
adequate,
can you see?
sorry.
Yeah.
Yeah. Please.
So this is done the moment they set foot inside the hospital, not when they come inside or anything. Moment they set foot inside the hospital, I stick this so that from AR to whatever procedure you're doing, they don't pull it down. And when you're seeing indirect also, it doesn't fog your lens. That is one more advantage.
Okay.
So
Fine.
this is something I practice.
Good.
So that's fine. Now, Rajiv, can you just introduce Anand and get him into the presentation?
Yeah, already introduced him, but
Okay.
I think Anand can start his talk on OT. Just one quick talk to a question before that. Many a times, especially in Chennai, we are seeing patients who are having a quarantine stamp. They are especially I'm sure at Agarwal, at Arvind, you are seeing them. So what you are doing for them?
We don't allow them inside, sir. Very point blank. Anybody with quarantine stamp is asked to go back home and call up over phone, and if possible, we'll give a video consult or a teleconsult and ask them to come only after the quarantine is over. This is point blank followed across the hospitals as of now.
But Chennai, do we have a quarantine stamp? It's
Yes,
Tamil
sir.
Nadu? Tamil
Yeah,
Nadu
yeah. We have got patients with a quarantine stamp, home quarantine stamp.
Okay, it's put on the dorsum of the hand. Huh?
Yeah, either if the patient has been wearing glove, they put it here in this forearm. So you will have to look in the forearm also, because some patients are used to wearing glove when they travel. So there they don't ask them to remove the glove and they put here, and then it might be here. So either both places we check.
Because on the right or left, because I don't know, all the patients will voluntarily disclose or not.
That we don't know,
put.
sir. We generally ask them. Our self-reporting form is there, and then we have the temperature check.
See, how
and then we
many
have the
times the
sanitizing
patient
protocol. When we give the sanitizer, we ask them to show their hands. So we don't actually look for the quarantine seal. We tell them show your hands so that we put the sanitizer. So we'll be looking at.
So indirectly you look into it. That's a nice valid point, I guess.
Yeah.
Because in voting we know we'll have this black mark in right or left. I forgot about it, but here at least we know that during sanitization we can ask them to look into it.
We can ask them, and it is either here or here only. We have seen like that only.
Okay.
Girish, would you like to add something on this?
Yeah, so I did speak to the health officials regarding this. So the challenge is for patients who are traveling from outstation, who have taken the risk of coming here despite the COVID pandemic for their medical condition. And if they are then asked to quarantine for 14 days, it defeats the purpose of their risk-taking travel. So what they have said is you do a triage at your end and see if it's an emergency or semi-emergency which requires an intervention with due PPE, you go ahead, and that's what we are doing it. So if the patient is otherwise a Chennai-based patient with a quarantine, obviously, as Preeti said, we will not be examining, but an outstation patient, we are making an exception and we are examining them.
Fine, now we'll move on to Anand, I guess. Yeah, Anand.
So I'll just try and screen share. Are you seeing my screen?
Yeah, Anand.
I'll just go to slideshow. Okay, so good morning, everybody. It's good to be here on this rig, and I think this is a very valid and a very pertinent topic that we are looking at today. So I'll just move on. So all of us are on a learning curve. There are no experts in the house or in the arena, and it's a balance. We're trying to balance safety and efficiency. And as you can see, it's a bumpy learning curve on the graphic, and kind of sometimes you feel that you've been framed. I certainly do. So a lot of the guidelines have devolved from this effort that we had put out, and I was happy to be part of this effort in the IJO. So this was sometime in late May, and things have moved. This was the time when we were all grappling with this issue, and now we know a little bit more. And this also in part made its way to the AIOS publication, which again we put out around that time. So I'm just going to first start with a video which was put together by our Arvind Pondicherry unit, and it reflects most of what is done in all the other centers too. And I'll just see. So let me know if it's playing or if it's not playing, Kasi.
Yeah.
Are you able to hear?
Yeah, it's moving.
See the video moving?
Yeah.
Yeah. So intraocular pressure, as I think Dr. Girish pointed out, that we moved from NCT to eye care and syringing also. NLD patencies tried with fluorescein. Pulse oximetry is something which we definitely do and do a lot more nowadays. And biometry is to be recorded ideally with the optical method. We keep an emphasis that one attendant has to be allowed only on the day of surgery. And most of our payments are online or digital payments. So on the day of surgery, a patient comes with attendant, there's a foot dispenser there. At the front of the building. And our staff checks the particulars. The thermal scanning. Then the moving. There's a no-touch drop installation where the patient themselves retract the lower lid. No-touch ID verification. Card payment or online payment transfers are preferred. And we have this auto rub at different points. So the staff, after every point of contact, would be encouraged to do that. Patient moves to the OT complex. The attenders waiting area with the social distancing. And then the shoe rack where they leave their footwear, street footwear. Again, we have a hand sanitizer there with the foot dispenser facility. And these doors have a push-pull technique where they can push them with their foot, or on the other side there's a small jut out which can be pulled out. The patient's old mask is disposed, and the mouth rinse and a face wash. Again, the sanitizing facility, and then they get to wipe their face and discard that tissue. A new mask is given. It's a 3-ply mask. Blood pressure and the pulse oximetry is done. SpO2 is measured, and MLOP has a face shield, gown, with 3-ply mask, head cover. Eye marking is done with the disposable bud. Again, drop is instilled with using a no-touch technique. Patient gets a clean OT gown, which is the color coded. It's different. It's red, and this is different from what the staff uses, which is usually green or blue. Footwear disposable. blocks are, we moved to subtenon blocks, and this is done by the doctor or the senior MLOP. The doctor here with a face shield and the PP. Glove disposal is done into a bin. Lens power verification is done. Only one patient per OT at that time, and the previous patient's plastic drape which is on the table is removed, and that is the table is clean, disinfected with 1% Lysol. And another fresh plastic drape is put for the head rest. Floor is again cleaned with Lysol by the cleaners. Once all that is done and the room is adequately disinfected, patient details verified, and the surgeon is in his PPE wearing double gloves. This is cataract surgery. Again, the no-touch eye drop installation, betadine, povidone iodine into the conjunctival surface, and once surgery is done, again, patient moves out. And after surgery, again, pulse oximetry is done and recorded. The gown is removed and disposed. Gown, cap, and the shoe, footwear, everything is disposed. Yeah. So that was a kind of nice video from Pondicherry. It kind of encapsulates everything very quickly. So I'll just go through in detail about the pre-op procedures, and we'll also look at discuss these steps again in detail. Yeah, like I mentioned, all standard precautions. Patient examined after refraction, diagnosed with cataract, advised surgery, undergoes IOP by eye care. Fluorescein dye disappearance test we've done, nasolacrimal depth syringing, only by authorized personnel, optical method for biometry, and systemic checkup, especially for our retina patients, is important. BP with electronic apparatus, follow additional disinfection protocols between patients, blood sugar as per existing protocols, ECG2. If the patient has any other systemic issues like cardiac, pulmonary, etc., physician fitness will always be taken, and this is mandatory for our retina surgery patients, especially. Pulse oximetry for all patients, any procedure, normal being, it has to be around 95, 96. X-ray, just CBC, bleeding time, clotting time, you've done only as advised by the anesthetist or physician if they deem it necessary. COVID-19 test as per government guidelines need not be done unless there is a suspicion and advised by the ophthalmologist and physician for us, specifically an anesthetist. And if positive, it is we would refer it to a COVID treatment center and scheduled after recovery if it's an elective test and a negative RT-PCR comes through. So counseling, there's a big bunch of things. Again, this is again derived largely from the cataract clinic protocols, but most of it is also applicable. I will highlight where things are specific for retina. Special COVID consent form, I think Dr. Girish has touched upon it, and it more or less applies to what we also do. For cataract cases, when we were between lockdowns and had a fairly large number, one of the ways of our managing that volume was to schedule everything in batches. Strictly, so we had a regulation, or we had some sort of a control on how many patients were coming in, and that could reduce patient time inside the hospital by doing it in batches. In retina clinic, of course, the patient's number is nowhere near what the cataract numbers were, but still, retina clinics, we were running surgeries fairly consistently throughout, and most of our patients do undergo admission. So things that the counselor would have to discuss, obviously, is the condition of the surgery and the patient's condition himself. What we mandate is that only one attender to accompany on the day of surgery. This is for cataract daycare surgery is preferred, and to come at that specified time, as I mentioned. All the instructions about personal hygiene, social distancing, etc. And they need to bring their topical and systemic medication in a transparent plastic cover. Fitness certificates to be brought. Unnecessary items to be avoided, wear clean and wash clothes on the day of surgery, and stay away from any social gathering before and after the surgery for 15 days. That's for elective cases for cataracts. That was advised. Any history of fever to immediately call and inform the counselor in the hospital. They're given the hospital number. As I mentioned, digital payments would be preferred. For these patients also, the day prior, they are confirmed through phone calls, and whether there's been in the intervening period any history of contact or fever. So again, just a bit of a graphic display of the way things are done, especially for cataract, when it's also partly applicable for our injection patients. So again, there's a separate entrance for inpatients, and thermal screening and hand sanitizer infection is done, as I mentioned. The consent, and this is in Arun, Chennai. COVID history form is filled, consent is filled, case sheet checking is done, online transfers are preferred, the wristband is tied on the patient. Again, the MLOP has a glove there when they do it, and inpatient dilatation drops. Patient again holds the lower lid, so there's no contact. Attender applies the eye sticker with right or left mark, or we are doing it as I showed in the video. The cotton bud with ink is used. In Arvind, Chennai, there are no stairs access to the OT, so it's only by lift. So as far as possible, we have only one person, patient or very couple at the most, going in the lift, riding in the lift. They go to the 4th floor. Again, like I mentioned earlier, case sheet checking, BP, pulse, oximetry. Pulse oximetry is done. In the ward or in daycare, again for cataract and our admission patients, the doctor to examine the torchlight. Doubtful cases can be taken with a slit lamp. All IV medications I mentioned, no touch installation. Dilatation started 30 minutes prior to shifting to OT. Avoiding contact investigations. Patient waiting area in front of the block room. A patient needs to dispose their mask. Again, as I mentioned, face, hands and legs to be washed. And hand rub and surgical mask is available there for a quick change. And the new mask is to be worn, like we saw in the video. Hand rub is also applied. And they don their cap, shoe cover, and a red colored OT gown. Case recording is checked, confirm eye marking, dilatation is checked. It's still topical anesthetics, 5% povidone iodine, 3 minutes contact time. Periocular cleaning by 10% povidone. And one always is particularly mindful about avoiding spillage of body fluid on staff or floor. And in the block room, the number of patients is limited. And this happened during those initial, second, third, and fourth lockdown. Block may be directly administered on the operating table. This also saves time and reduces unnecessary contact. If any type of block is given in the block room, to monitor again, like I mentioned, with the oximeter. Subtenons, as you saw in the video, with an eye towel, and collect everything from the OT store, case sheet, and consumables, not to hand only by staff, and not to hand over to the patient. Hand hygiene at all points of time. In the OT, only one staff is posted for patient transport from the block room to the IOL store, and then front staff from IOL store to OT waiting area. Hands are always to be cleaned with hand Aurora before OT, entering OT. Aurora, as you know, is 0.5% chlorhexidine gluconate and 70% isopropyl alcohol. One patient at a time, as I mentioned. Topical anesthetic application, povidone, as I mentioned. It is all standard procedures. OT preparation, again, BP and pulse monitoring is done. To continue wearing the mask in OT as well. If the patient is uncomfortable or needs an airway, to lower the mask to expose the nose alone. And as the patient is wearing a coat, top sheet is not really required. This is for cataract surgery. Make sure drapes near the nasal side is strictly secured with adhesive sticking. And like our micropore, as we mentioned, the bag has to be secured well so that all the fluid waste is collected without spill. And to apply the tape under the mask and use the Aurora right after. So that's the right way of doing it on the right side. The tape shouldn't go over the mask. Mask should be lifted and it should be inserted and stuck under the mask. And then, of course, the staff should use the Aurora. After every procedure, OT needs to be cleaned. All the points of all the surfaces, computer table, bin, rack, surgeon chair, door, knobs, other surfaces disinfected with Lysol. MLOP to clean these surfaces with the Lysol spray. A Rexine sheet to be cleaned after each case. Separate cloth for patient table and headrest. Between cases, as you saw in the video, OT floor to be cleaned with Lysol by cleaners. To also clean the foot pedal. Wheelchair to be cleaned, staff and surgeon staff to use double gloves to change the outer glove if you're doing multiple cases, and the biomedical waste to be removed as per standard SOP. At the completion of surgery, as you saw again, remove cap, shoe, and the coat. A patient's room, proper sanitization and cleanliness for patients who are in admission, especially for a retina patient, twice a day to be done with including emptying of the bins before admission and after discharge to clean the floor and all surfaces. So what remains the same, I mean, a lot of our procedures and protocols have been good and they do hold. There's no need to, in a panic mode, change everything. Perioperative antibiotics, autoclaving protocols, validation, surveillance, linen management, biomedical waste management, all these can continue. A little more specific about retina OT, as I mentioned, retina, the red OT gown, triple mask, footwear. Patient is escorted into the OT in a wheelchair, especially if they're high risk. One-eyed patient maintaining norms of only one patient on table. On the table, all our patients' mask is lowered a little for the oxygen tube. This is more specific for retina OT, and placed back once tube is in place by patient himself or an MLOP with gloves. Hand rub is given to a patient at the end of surgery. As I mentioned, all these surfaces are cleaned. In the retina OT, as I highlighted in that discussion, OT dress, we use N95 or an FFP2. FFP2 and N95 are equivalent. FFP1 is not equivalent to N95. And over that, we use a surgical mask, scrub in the waiting area. We follow a donning process. I'll show you that in a bit. The photographs. We use a coverall PPE kit. Then the first glove comes on. Then after that, we have the external glove, OT gown, and the second glove to be worn over the above PPE. Goggles. In our retina OT, we have the Ingenuity, so we have the goggles coming in with that. So we use that specifically. Using anything over and above that makes clarity a problem, visualization a problem, and of course footwear. Hand rub is applied over the first gloves before changing over for the next patient in the event that we have multiple patients for surgery that day. Doffing procedure, what we do is we remove the external OT gown and the second gloves and the footwear in a sterile corridor. This we've been fortunate that in urban Chennai's complex, OT complex, we have a sterile corridor on the side. And I'll show you pictures of that too. So we do that doffing procedure there. And we dispose them in the bins placed outside there in that corridor. And we have two bins there, one for OT gowns and one for the gloves. So the sequence would be one, this is the coverall, it's white in color that we had, that we got recently. Doctors also wearing an N95 or an FFP2 and a surgical mask over that. The first pair of gloves comes in. Then after that, the green gown, which is replaceable, as I mentioned, if multiple surgeries are done, only this one is removed, and then you'll see that. And the second pair of gloves comes on and is worn over, so it should overlap and go over the green gown. All right. And then this green gown and the second pair of gloves is replaced, changed between surgeries. For every surgery, you get a separate second pair and the green gown. And this doffing, as I mentioned, is in the adjacent corridor. So all of us do Ingenuity. It's what we use continuously, so that, I mean, it's to some extent a little safer in the sense you don't have to peer down on the patient and you can stay a little away, and you can see the Ingenuity goggles there too. For injections, again, most of the protocols are the same, and I've also already mentioned it. Standard ASEPs is, as mentioned, coverall, gown, double gloves. The surgeon uses N95 or FFP2 with the surgical mask, and otherwise the standard injection procedure is followed. And this is the doffing, where this is the addition sterile corridor. You can see that, you can see the OT through that, and you can see that the doctor is discarding everything right there and then. So most of this I've already mentioned. It's just that, again, between cases, all the surfaces are cleaned and floor is mopped. Between patients, the running MLOPs, for them, we have this protocol, the OT dress, cap, 3-ply mask, gloves. Again, their job is to ensure that all surfaces are disinfected and hygiene continuously, periodically, they're encouraged to do. OT equipment, this is something, you know, when we were discussing how to go forward with, you know, the cassette and tubing. This is a prickly area, and many people have different views about this. But I personally thought that cassette and tubing should be changed for every patient. Tubing, of course, is changed, that there's no brainer there. But what we do with cassettes is, because we're doing just probably 2-3 consecutive, what we do is the cassettes are removed after each patient and we label them alphabetically. For example, if you have 3 patients that day, then we will have cassette A, cassette B, cassette C, and then we at the end we mark it 1, and the next time it comes on, it's marked 2. Next time it comes on, marked 3. So cassettes are discarded after 4 uses, and each cassette is sterilized, autoclaved at the end of the procedure by that assisting sister wearing the PPE that she was wearing. And this way, we consecutive patients are not subject to the same cassette, as well as we retain the dual advantage of maintaining cost effectivity. So this is something we can. This is something we are doing. Going forward, when numbers increase, we may change our protocol, but this is what we are doing right now in our Chennai. Sterilization protocols and reuse practices more or less the same. There is no need, and this is what we mentioned in that article also, there is no need to alter conventional preset institutional protocols as long as they comply obviously with the manufacturer's recommendations. We do not reuse residual silicone oil and PFCL in this period, which we used to do earlier. As of now, because the cases are less, we are able to use a fresh bottle of Rinalactate or Valence salt solution for each case. Specific to retinal surgeries, I think the one thing is about valved and non-valved cannulas. It is definitely preferable to use valved cannulas, as much of the fluid spills and the bubbling which happens during FAE can be avoided. A non-valved cannula system, as we know, can cause some definite amount of spillage of fluid or air over the surgeon, especially with the IOP control machines or high bottle height. And therefore, if you have a valve system, it's better to be mindful of reducing the bottle height or not unnecessarily, increasing it, and ensure that instrument exchanges during that point of time, there can be sclerotomy leakage. And I haven't put it here, but I've even seen, valved cannula systems with reuse can spill over. Even I've got a clipping where I've got an absolutely fresh valve cannula system where there was leakage and bubbling spill rush through a fluid, just with a not very high IOP setting. Also, another little modification is, which we suggested in that paper, is to use viscoelastic OV irrigation to keep the cornea wet rather than spraying or shooting saline on the cornea, which can again potentially raise aerosols. A non-contact viewing system, I think almost everybody uses that. That is to be preferred. Diathermy, of course, we don't do it to the extent of GI surgeons or gastrosurgeons, but still it is it's accepted as a known source of aerosolization, and any needing diathermy should be carefully considered. The issue between scleral buckle versus vitrectomy, of course, we have not done huge bunch of cases, but in any case, even fresh RDs, we prefer to go in for vitrectomy, because with scleral buckle, we have to open up the conjunctiva, do a lot of cautery, and all those things can potentially increase the aerosol generation. And choice of procedure, of course, is detected by the eye condition. But again, we veer towards vitrectomy, which we know is a closed system and has a lesser potential for generation of aerosols. Like mentioned again, during past planar vitrectomy, be mindful of fluid spill. This happens, and you have to be mindful of that high pressure bubbling. Avoid it by using active rather than passive aspiration. Minimize instrument exchanges. I think you should have a plan of what you're going to use rather than a regular system. Experienced surgeons should do the surgeries whenever possible. This is what we're doing. And over time, as protocols are crystallized, trainee surgeons would be expected to also operate. So as of now, even some oil removals that we've had to do because of emulsification, high IOP, we've let our senior fellows do that too, since we've got our protocols nailed down a bit. This is the prioritization of surgeries, which again, this table is there. Emergency surgery, semi-emergency, elective surgery. I think everybody here knows that acute RDs, open globe injuries, submacular hemorrhages, aqueous misdirection, etc. ROP surgery, these would constitute emergency surgery, which we are kind of obligated to do immediately. Semi-emergencies, which perhaps you can push back a little. Macular holes, ERMs, heavy liquid removal, elective surgeries like ERMs, oil removal, we can push back a little. So thank you. That's all that I have here. So it's been a pleasure.
Thanks, Anand.
Yeah.
Any questions for, let us see the question box. I don't think many, he has already covered. There were some questions. Atul wanted to know any special precautions for scleral buckle.
Yeah, I mean, scleral buckle, frankly, we have not done in this, 2 months, 2.5 months. But like I said, if it's possible, see, the success lies in the hands of the surgeon. So surgical retina is not like medical retina. I mean, a lot of the success is dictated by the surgeon themselves. So if you have to do that, like I mentioned, you should be mindful that you're doing a procedure that can potentially raise aerosols. You have to be very careful with your, first and foremost, of course, you and your assistant has to be in the proper PP, as I mentioned. Be mindful that when you do the conjunctival, you're opening up 360 degrees. The conjunctiva, a lot of blood spill will be there. Fluid spill. Jury is not out as to whether this virus is there in body fluids and blood. But let us be. It's better to be safer than sorry. We do not know the same. So you'll have to make sure that your cautery is perfect. And otherwise, nothing much more. Avoid fluid spill to the best of your capability. But I would say that if a surgery in this period of time, given how bad we are in Chennai, and we are not testing. I mentioned that, and I think Dr. Girish also mentioned, we're not testing everybody. Also, please remember one thing which we never brought up, and I think I should mention, is this test, COVID test, has a 33% false negativity. If it was any other test for any other disease or pathology, this test would fail to qualify as a diagnostic test. It is purely because this is what we have that we are doing it. We know of patients who have been on ventilators who have tested negative. And after the patient is expired, the third test came out positive. So this test is not the holy grail. So we do not know who is there. Therefore, it's important for us, everybody, to be as careful, especially when you're doing interventions, and more so when you're doing long procedures like retinal surgeries. Because the most important thing we have learned about this disease is that it is a viral load to which the surgeon or physician is exposed, which is going to drive things. So by taking up a scleral buckling surgery, you're exposing yourself potentially to much higher aerosol generation and potentially viral load too.
Anand, one point I would agree with scleral buckling with vitrectomy. Given a scenario, the time taken for scleral buckling is slightly more than a vitrectomy for a particular case, say a superior HST. But is that the only thing? The time is the only factor you think that vitrectomy is better than scleral buckling?
No. It's not the time. All right, what I meant about time was that all retinal surgeries are more than your regular cataract surgery. It's not just the time. There are many people who would probably do buckling faster than vitrectomy, especially my teacher.
I know quite a few like that.
Number one, Sami, who do it in about 20-25 minutes. So what I mentioned is you're opening up the conjunctiva.
But does it increase? As you said, the jury is still not out. We don't know the fluid-containing virus.
So
but,
and how much of cautery you use in a scleral buckle, Anand?
There's a.
Why would you use cautery in a scleral buckle?
To market.
I'm saying the conjunctival surface. When you're opening up the conjunctiva, if there is a bleed, you'll.
I'm not used to it. That's why.
More you would for a vitrectomy, where you don't even have to, touch.
No, because that's the only point I would beg to differ. Because vitrectomy with scleral buckling, which is safe during COVID, I don't think so that really any matters. But that's
I think it's equally, it's pretty much the same.
So actually,
in my opinion.
I would just share one of the things which we have been doing is we've been trying to measure these aerosols with a tubing attached to the microscope, and we looked into all the steps of surgery. So it was a proper vitrectomy with a belt buckle, and belt buckle actually doesn't cause much. More was when the vitrectomy was done.
True.
So I don't think that it's we expose more, but it doesn't mean that that releases more aerosols. Unlike the oculoplasty procedures where really cautery, bone cutting, and all those steps produce more, but I don't think buckle alone is something which we should avoid.
And then the fluids which we do not know. Nobody knows. Sure.
Because we're still not sure. Krishna? Unmute yourself, please.
Any questions are there? Any more questions in the?
I actually have a doubt on what Anand said towards the end. Anand, I totally agree in theory that when you said if I have a ROP laser or a MAC on or even a MAC off RD for that matter, I'll operate him. Whereas I'll postpone an ERM or a macula hole. But let us take, for example, I saw a macula hole 2 weeks back. Fresh macula hole, 618, 612 vision. I would be happy. I'd say pretty much wait for a month or two. It doesn't really cause much harm. You can wait for a month or two and operate. But his question was, doctor, do you think it will get better? Things will get better after a couple of months. So that's a moral dilemma. So if you're going to postpone a surgery, and I agree, if you're having a NS1 with hardly 612 or 69 vision, you can ask him to even come after 1 year, because the result of your surgery is not going to change even if it takes more than 6 months. But can you say the same thing for a macula hole?
No,
if you operate after 6 months, you think the result is going to be the same?
Only guidelines.
I think,
yeah, that's a moral dilemma. That's why I said it's a dilemma.
I think this guideline was developed in the beginning of the COVID. Now there is no elective emergency.
There are changes which are happening. Like we were not treating DME injections, but now we are injecting. So I think
we do cataracts. By 612 vision, patient is symptomatic, we do cataracts now. So I don't think there is elective, semi-emergency, emergency at the moment. Whichever patient needs a surgery, we need to go ahead with that.
So it all depends on your location.
I think we should put it more like, rather than calling it elective and emergency, I think we should categorize it into two things. One is, if delaying the surgery is not going to change the outcome, ask him to delay. If you think, not only surgery, any intervention, even a laser, even an injection for that matter, if a delay is going to make the outcome worse, I don't think there's any point waiting, because you don't know how long you need to wait for it. Simple example is what Rajiv said, injection for DME. You can ask him to wait for a month. Yes, nothing wrong in it. But how are you sure even after 6 months, probably we're going to be only worse than what we are now? We never know.
So that's what, Sriram, these are all relative guidelines. So it is about endophthalmitis.
No, I'm not contesting what you said. I'm saying that's a moral dilemma which I faced while talking to a patient.
So this is all.
Vasubhati had a question. I think
a quick question actually. Supposing it's just, I've been thinking about it. If there is only one case in the OR that day, then is there any real rationale of putting a PPE? There is an overall, which you mentioned, Anand, and then a surgical gown, a disposable surgical gown?
So the PPE is, it just adds another layer to your protection. That is all. It also depends on that patient. Whether if that is
granted that we do all the pre-op these things, and
so this is something we are just following. We've sang a requisition and
multiple cases. Yes.
Yeah, no, that's fine. But having two gowns just adds to your protection. It's just
to your discomfort also.
Yeah, no, but I've done quite a few, about 30-40 surgeries with these. I have not had, and personally, I have not had, and none of my team have any. It's a very light one. Particular thing which you're saying, it's a very light one. It's only added. Everything is to your discretion. There is no definite mandate. This is what we are doing, and we are comfortable, and everybody feels secure, less vulnerable.
Yeah, Krishna.
I think I'll put it like this, Anand. Can I answer Vasubhati's question?
Yeah.
Rajiv, does SL
1 second.
We are just using the gown. We are not using these double gowns. Starting, we were using double, but now we are having only a single gown.
So, can I answer Vasubhati's question?
Yeah,
please.
Kasi, two things. First, let us assume you're testing. You're not testing, but let us assume you're testing. Like Anand said, RT-PCR positivity rate is 60 to 70% maximum. If you combine RT-PCR with a chest CT, your positivity is 80 to 90%. So still 1 out of 10 patients you're going to miss. So it is important you take the same precautions for every patient you come in contact with. The only difference can be OP and OT, because in OP you can be confident you'll finish within 5-10 minutes. In theater, it is going to invariably, even if it's a cataract, it's at least going to be 10 minutes, if not more. And we are certainly going to be more. So this question of whether should we use 2 layers or adequate PPE if it is more than 1 patient or less than not many patients, the protection is not for between patients alone. The protection is for you and your team. So if that 1 person you operate also is liable to infect you, 10 people you operate also, you're liable to get infected. So nothing is more than this question of uncomfortable, something you PPE or some protective equipment you being uncomfortable to you. Nothing is more uncomfortable than having a ET tube in your throat. So I think we should totally forget this thing about having something being uncomfortable for us.
Yeah.
If it is necessary, it is necessary. If it's one patient, if it be used for 1 or 10 or 100, it should be used. As simple as that.
That will lead to individual
PPE,
discussion.
is it over and above the, I mean, under the disposable?
No, I'm not suggesting you use. What I'm saying is you should not differentiate between one and more than one patient.
So if you
can have a rule,
I
you can
was
say I will use
to
this, I will not
Anand's
use
presentation in which he mentioned that if there are multiple cases, the PPE remains.
That's
overall
what I'm
count
saying.
changes. What I am trying to understand is whether everybody across the board, like Rajiv has clarified that SN no longer uses. I would want to know whether
I don't use. Even
I don't use.
See, what I use
Sriram, do you
is
Sriram, do you use a PPE?
No, he doesn't.
I don't use a full PPE kit. What I use is I use a long legging, waterproof legging, so that in case during surgery, because
Just
imagine
now
you're
you said you
protected
should not be
from
bothered about discomfort, and you're
no,
saying
I said whatever you use, it doesn't matter if it's 1 case or 10 cases. That is what I said.
Yeah.
If you have a protocol,
that's fair enough. No, that's fair enough.
That was
but
my
then,
point.
Okay. Let's leave it. Leave it to the private chat. Krishna, a point from you.
The moot point here was that one regarding the buckle and the vitrectomy. I think Anand ultimately summarized and said that ultimately it's the decision is based on the case. I don't see whether we have exactly put the risk on vitrectomy is more or buckle is more yet. But I think as the case demands, ultimately what are we? We are care providers. We have to be truthful to our patients. So whatever the patient deserves is what we have to give. What care we need to take is our concern. So we have decided that we will take all the care and precautions required to protect ourselves. Once we are comfortable in our mind that we are adequately protected, this is where the PPE part comes. In your mind, if you are comfortable that you're adequately protected, logic says that, look, this is enough for me, then I think you've done it. Bottom line is you have to be without any stress of working day and night. If you are comfortable in your mind, this is adequate for me, PPE or no PPE is secondary. But logic will dictate minimum amount of protection that you will have to take. And that is something which you will have to take. I myself don't use a PPE when I'm doing retinal surgeries because spillage on the body is less. Your lungs, your nose, and your airways are the most important ones which you need to protect.
Absolutely
and make sure that you don't compromise there. If you don't compromise there, whether you have 2 layers, 3 layers, 4 layers, in a job where you're not coming in contact with body fluids directly, it may be overkill sometimes. But again, I say, in your mind, if you are not just your mind, your people who work with you also have to be comfortable, saying that, look, they're adequately protected to work here. Once you reach that, then let that be the protocol. Third thing, again, which Sriram said was that, see, with every kind of testing that we are going to talk about, we will never reach 100% sensitivity as far as COVID is concerned. So that means we've already come to the conclusion, every patient is considered COVID positive when we are taking all these precautions. Then the corollary is also true. Do we need to test our patients before surgery then? Because I'm already considering him as COVID positive. Unless there is any symptoms or anything to suggest that he is COVID positive, where possibly we may have to take other people's help to take care of this patient. Doing a COVID positive and coming out positive in asymptomatic patients throws up a whole lot of other things for you as a healthcare system, which you would like to avoid unnecessarily. Because right now, many people who are just walking around are coming positive. And you might see that many of our own colleagues here who are doing a pre-op test have turned up with patients who are turning positive. Then what do? BBMP comes over, then whoever has come in private contact goes into quarantine and things like that. So I think we have to be scrupulous as to how we are going to adapt and adopt things, if it makes sense to us at all or not. If we are adequately protected and the patient understands his risk as he walks into this hospital, I think we should leave it there for the time being. And the rest, of course, the directives will come from required government facilities and health facilities. We'll have to follow those. But apart from that, where it is within your space, I think we should be a little more practical. And like Sriram once again said, there's nothing that you can postpone now. You have to get used to working with this for the time being. Otherwise, many of these institutes will go under. We won't be able to sustain if you're going to push cases away.
So that's why I said there's no emergency, semi-emergency, or elective.
Yes. You will just need
whatever cases need surgery, go ahead.
And one small clarification, Kasi.
Yeah, let the patient take the decision.
And what I feel is what is said is right. Whatever be the surgery, we have to do it. But we are going to do it for a long time, like 6 months. See, though the sensitivity of this test is only 70%, the test is very specific. So if the government recently has come out with a guideline, like ICMR has said that For all elective procedures and for asymptomatics also, you are allowed to do a RT-PCR. So if RT-PCR is going to be available more and more, if the antigen testing is going to come up, we would rather go ahead and do a test, and at least those specific cases we can be let out, and then we can do the other cases with more confidence, with all the PPE, of course. So what I'm trying to say is, if the government has already come out saying that ICMR itself has said that for surgeries which were for elective surgeries also we can take that advantage, and if possible we can get it done. This
Okay,
is
so
my take.
let's start with the questions now.
I think most of the points will be covered there as well. So Rajiv, start.
So let's start with Dr. Vasumati. What changes in the theatre you have done?
We have not done any structural changes and all that. It's just that we take in only one patient at a time, and after that patient is over and done with, outside do we bring in the next patient, even if it is for an injection. Like for example, previously we used to have 3 or 4 injections in the area just outside the theatre. We no longer do that. We take in one at a time, and we also try to put N95 masks for the patients also.
Okay, fine.
The 2 small things which we have done.
Anybody has done any change which you want to highlight here? Emphasize?
Just what?
I have installed UV lights in my ducts. That is one thing I've done. Both the intake ducts, the air mixer on top in the AHU, and the return ducts, I've installed UV lights. That's one change I've done. And well, another change I've done is I've installed a sort of a closed exhaust system in my scrub area. Because my theatre is like, there's something like a wind tunnel. Whatever air is in the theatre, it comes out and comes out to the outer area where people are waiting. So generally, those people waiting outside, that anesthetist who's sometimes sitting outside, the OT secretary, etc., they are not as protected as people inside theatre. They are always a little casual. So it is something like the whole air keeps going outside. So I sort of put an exhaust in the ante room which pushes the air out, so the theatre air doesn't go to the other areas. And we use PAPR devices in theatre. That's one more extra this thing. We use 3M's PAPR devices, 6210 filters.
What these filters are?
This is the big mask. You want me to show you one?
Okay. That we are like the current what movies like
Avengers.
Okay, this is how my theatre nurse looks like.
Okay.
So we ourselves.
This is my theatre assistant.
Okay. So like Avengers series, huh? Wonder Woman. Huh?
Yeah, something like that.
Avengers.
Looks like they're going to the moon.
Yeah, Wonder Woman.
Kasi, we have tried to do in our OT. We have not changed anything structurally, but where I was quite impressed by what Dr. Girish showed, especially with respect to the GA cases, because GA cases are still a problem. But for us, the concern was 2 things we had to take into account. If we make our OT 0 pressure or negative pressure, then the problem is that all the effort we have taken to reduce infection rate is nullified. So our primary concern is still infections. Make sure that our surgery does not go wrong. So that is still the primary concern. So we kept the positive pressure going. Anyway, the air comes from the top and it blows to the bottom. So you are at a higher level than the patient at all times when you're operating. So it goes down from top bottom. So we maintain the positive pressure. But what we do is that in between patients, especially after general anesthesia and other things, we allow at least about 5 to 6, at least 95% of the air to recirculate before we enter into the OT again. So we just walk out of the OT before the next patient, give it 15 to 20 minutes time, depending on the cycle rate, which is there in your hospital AHU system. Allow the air to recirculate. It will take more than an hour for 100% recirculation, but within 15 to 20 minutes, more than 95% of the air is recirculated. First cycle 50%, second cycle 75%, third cycle 87.5%, fourth cycle above 90%. So all you have to do is allow the air to go out and then come in and start working again after disinfecting the surfaces. So we've basically not made too many changes as such, but at the same time, especially for GA where there is unseen risk, which we are expecting, we just come out and allow the air to exchange completely and come in again.
Yes, any theatre?
So, I mean, we're following all the practices which have already been mentioned. I'm frankly not sure whether how many of them are necessary or useful. But one thing which I probably truly believe might make a difference is the fact that among all our AHUs across centers, we have fixed the amount of air exchanges which happen. So one of the reasons why we are happier in OPD is not just the fact that of lower exposure time, but there is adequate ventilation, fans, windows and doors which are open, which is not there in an OT setup. So normally the AHUs, whether it is most of the companies like Blue Star or Dakin, have kept it at around 20 to 22, which is what is being done. It can be raised up to 50, but the problem is maintaining temperature. In Coimbatore, we are blessed with better weather, and we are able to go even up to 40, 42 and maintain a temperature of 26, 27. Bangalore, we are able to do the same thing. Across Western Tamil Nadu, certain other branches we're able to do. Cochin, we are not able to do that. The humidity level is higher. So we are having to titrate it to make it tolerable and safe to operate in the OT. At the same time, increase the exchanges as much as possible so that whatever aerosol is released stays in the OT for a lesser amount of time.
Okay. And Preeti, anything from status from Agarwal and Kaushal?
Installed a new AHU, so I didn't want to put UV for the filters, though I'm contemplating at a later stage because right now I don't want to make any changes. Only thing I'm doing is just like Anand told, I use a disposable gown over my surgical gown. So I'm really concerned about the care of my feet because they keep operating for a longer time. I don't want the irrigating fluid to come and drop down anywhere near even the lower part of the gown at this times. So I make sure there is no fluid spillage down to the lower part of my legs, because it used to happen quite occasionally sometimes, but I don't want that to happen. So I use a disposable gown over my surgical gown and operate the case.
It's other way around that what Anand said.
Yeah.
Just one small comment, sir.
Footwear you need Kaushal for that.
Shreyas.
Yeah, go ahead.
No, sir. Was just wondering. I mean, for all our surgeries, I'm an anterior segment surgeon. I do cornea and cataract surgeries, but I can't replicate that for vitrectomy surgeries. But the minute we enter the anterior chamber after our paracentesis, the entire aqueous is being replaced by a viscoelastic. So phacoemulsification, which is very much an aerosol producing equipment, and definitely side port leakage, main moon leakage, definitely aerosols are being produced. But what we are actually aerosolizing is the BSS which is coming from the machine. And is that BSS, even if, let us assume COVID, even if it is present in the aqueous, even though there is no data to prove that till date, but what is actually being aerosolized is not the aqueous, but it is the BSS. And I'm sure even in vitrectomy machines, after some time, it is the fluid which is going to be aerosolized. So whatever is dripping onto our gowns or our pants or our shoes is most likely the BSS, and I'm not too sure whether that is something which we should be too worried or concerned about.
Point taken. As Krishna said, it's whatever you feel in your mind, that is better. You are given adequate protection for yourself. If you are convinced about it.
Sometimes in diabetic vitrectomies, the bleeding from inside also spills out. So true that it's only the BSS or the RL, but intraocular fluids also do come out, Shreyas. So we have to be careful about our feet, the VR surgeons.
Yeah, Dr. Girish.
Yeah, I had the same point that in VR surgery, the BSS does get mixed with the blood at some point. So it's not as sacrosanct as an anterior segment surgery.
So it's like
so we can categorize like diabetic surgeries where you expect bleeding. Take care of your foot. When you're doing a macular hole or ERM, when you don't expect much of bleed. Something like that's
in
what.
Agarwal, with respect to Agarwal Eye Hospital, most of the centers which are there are having a HEPA filter, inbuilt ultraviolet units, because most of it have been built recently over the past 3 years, and all these have HEPA and UVC lights also. So with respect to that, we haven't made much changes, but of course, we are following all these protocols which were currently mentioned, like including the time in between the patients, so that we allow the air exchange to happen, even though it is cataract. And one advantage of operating in small centers is that you don't have to face a lot of volume. The maximum number of surgery which decently working center would do is around 10 per day. So you can actually space the surgeries so that you would definitely have gap in between the patients, and you can schedule and do it. And also wherever we have the AMO machine where we don't have to use the cassette, we can change the tubing with every case, like how we generally the Agarwals do. We opt for the AMO machines, and wherever there is a cassette, we have at least 2 cassettes which we change and operate. This is what we do. No specific infrastructural changes have been made because we were not sure how far this is going to go and how long this is going to exist.
I think Anand had already mentioned about measures which they take to reduce the patient time in the theater. Anybody wants to add any point?
Just one point. Just 1 point. What measures you have done to reduce the patient time inside the theater to cut short the time? Yeah, Dr. Vasumati.
Okay, I'll just give the first point.
Yeah.
Well, I don't wait for the patient to come in and lie down on the couch before I scrub. Everybody, the whole team is scrubbed and ready to start before the patient is wheeled in.
Good.
Usually
Very
we'll
good.
make the patient
Very
lie
good.
down, have a couple of words with him, then go
Yes.
out, scrub and come
Yes.
in. I don't do that. That's what I usually used to do. Now I don't do that anymore. If it's a VR case, I just drape him with the topical anesthetic and do a subtenons and proceed. If it's a cataract, I just do the surgery under topical anesthesia itself. But I ensure everybody is ready and waiting to start the moment he walks in.
That's
So
a
that
very
is the only
valid point.
way I can
Very
reduce.
valid point.
I don't have
Very
2 tables. I don't have a large volume, but that's the only way I can reduce. And one more point which I wanted to make regarding this overall, this over that, full overall legging. It's very important when you remove it, you dispose it properly and then wash again. That is very important because this is what I initially saw in my theater staff. The moment the session is over, they immediately take off the overalls, take off the mask and wipe their face with their hand. It is an instinct which everybody has. So that is one very important thing. When you finish, take off everything, dispose it properly, and again have a thorough wash, remove your mask, dispose it if it's disposable, or do whatever is necessary for it. Go have a good wash before you touch your hands and take your hands to your face.
So
that is very, very important.
Yeah, 1 point from Shreyas.
Sir, no corneas, no long surgeries. So no corneal donation is there, so we are not able to do many corneal procedures. So most of what I'm doing now is only phaco and refractive, which anyway is only 5 minutes, so 10 minutes, so not much to time reduction. But yes, for our VR surgeries, just on an added note, they are scheduling the surgeries in such a way that it is more distributed. Obviously, the number of VR surgeries are not as high as the number of cataract surgeries which is being performed. So patients are given adequate intervals before which they are called. And while we can't demand of them to reduce surgical time, at least the spacing between surgeries can be increased.
Dr. Vasumati.
Yeah, same thing. We generally make sure that we are all ready when the patient comes in. So that is I think the easiest and the most practical way.
Anybody has any other point to tell about patient time? Otherwise, we'll go to the next question.
Krishna has anything to say? Krishna or Kaushal? Nothing.
I just wanted a clarification about the ICMR protocol, which Preeti was mentioning, that even asymptomatics can be tested or something like that. Is it true? ICMR, has it come out with something?
Preeti, you're muted. Preeti, you're muted.
I thought ICMR had told that we could do antibody testing.
Preeti, can you unmute? You are muted.
Yeah, unmute yourself.
I can share, I can share the protocol, madam. The latest one clearly says that any pre-op patient can be tested, especially those with aerosolizing, expected aerosolized procedures can be officially tested for RT-PCR without having any quarantine. That is a recent which has come out.
Preeti, you can share that article with us in the RIG
WhatsApp.
WhatsApp.
I will definitely share. Yes, sir.
In the WhatsApp.
This confusion is because
share also.
I think this confusion is because ICMR said preoperative
especially
COVID testing is
And
not
now
mandatory.
they are not quarantining such kind of patients also. I have had even for cataract, I have done RT-PCR for a couple of patients in my setup, whichever I had doubt. We initially had a lot of protocols, and then we gave the authority to the specific medical heads to decide according to their state and their government restrictions. In Chennai, when this was out, we started doing the RT-PCR for some cases. So none of my patients were asked to quarantine also. So I can send you that, madam. After this,
you can put it in the WhatsApp, but it's the other way around. One patient, when I asked them to do RT-PCR, he came out with the big, he WhatsApp me the ICMR guidelines. So for an elective surgery, it is not needed. If you suspect a COVID in that patient, you can do
Yeah, that was
So
my
the patient
No.
asked me,
Just a
do you
play of
suspect
words,
COVID?
I can send you down now because I am not.
No
I
worries.
can send
That
you
is,
right
if
now.
it has
No
come out with
problem.
something different recently, it's a big relief, actually.
Well, if that is
Yeah,
the case,
it
it's
is
good.
very clearly written in the recent ICMR that you can also do it for.
So you can forward to the RAG group.
Yeah, yes, sir. I'm just
No,
seeing
just a
where
question
it is.
of play of words.
Yeah.
Just a play
Yeah,
of
I know.
words.
I
That's all
mean,
it
it's
is.
really,
Actually, what
They
happens
say it
is
is not
Yeah.
mandatory.
Yeah,
and
It
also
is not
question of your
mandatory.
luck.
That's all.
yeah. Send
what
out to
happens is
Grisha.
the ICMR and the Ministry of Health always comes out with directives and then adds a last line that the states are able to modify this as per their.
Yes,
Yeah,
that is why I
and
mentioned
Absolutely, sir. I
that
was.
depending upon the state also you will have to have changes. But as far as Tamil Nadu is concerned, they are not very bad. And in fact, in Chennai, I have really done around 4 to 5 patients RT-PCR so far, and I have operated cataract. So the day
Subject. Health
the
is
only
fact,
thing is
in,
patient should be willing to undergo that.
That's
So what we do is we didn't want to send the patient to the center. We have in fact arranged for a home collection kind of thing where the lab fellow comes and takes it in our own premise itself. They charge you another additional 500 rupees, but the patient is not exposed to other
even
COVID
then,
patients
if it,
or to other things. We were also sending for HRCT in between when this was not available. Some of the branches were sending it. And such patients also, we felt that a lot of HRCT was happening because of this COVID. So we were always worried whether they will contract something from that place where we sent. So after this home collection, we were able to organize. We are finding much safer for the patient also and for us also. The only place where we have trouble is the cost. So we try to explain to them that it is safe for you also because the other patients also getting tested. So you're not getting exposed to any COVID at least.
Preeti, the patient didn't ask you, have you tested yourself?
They did, sir. Some patients did. Some patients asked. Actually, I have done for myself, so I was able to answer. See, that is where how we operate in Agarwal. Like there is a common platform which gives us the all the protocols, and then we're also given a thing that if COVID testing is if possible, you can do it. We don't mandate so that we also consider the other locations, but wherever possible, we are able to do.
The one patient asked me, have you done COVID on yourself? I said, yeah, I didn't think of it because if I have to do it every day or every alternate day because we keep operating alternate
Don't
days.
tell him that, Kasi. Don't tell him that. Do it once. Hang it up in your
Yes.
consultation room.
Exactly.
Anybody
I
asks
am a
you, show
COVID
them that.
negative
what,
doctor.
Don't tell him the validity of the report doesn't last for more than 48 hours. Do it once and hang it up in your consultation room. Anybody asks, just show them the report like that.
I have sent the thing in the RIG groups, the latest
we will see that.
ICMR, this
Rajiv,
thing, sent it
yeah,
to the entire group.
We'll go
Rajiv,
to the
yeah, next question.
Somebody can
go to the
project
next
it.
question.
Yeah.
No, you
I
can just put
one,
it in there.
Rajiv, I just have
yes,
one suggestion to Preeti. Just
Yeah.
ensure that wherever you're getting your lab tested,
Yes, sir.
COVID test, they update the ICMR because it's very
Yes.
important that they should be sharing all that with the ICMR because that
Yes, sir. We are in the Agarwals are tied up with Anderson's and High Tech only. Both labs are accredited for doing RT-PCR.
Responsibility of sharing it with the ICMR is with the team which is ordering the test.
Yes, sir. We are ensuring only that the lab which we are accredited with is sending every report to the ICMR also.
No, but as with the evolving guidelines, initially when these tests has to be done for elective, the ICMR didn't have a guideline for elective surgery.
Correct.
So we
Now
were
we have come
scared
up.
because we have to send the lab has to send the feedback to ICMR, but why this COVID was done. So in that scenario, we were worried that the hospital will be said that this hospital advised for elective surgery. We were worried about the repercussions. But now with the evolving guidelines, as Preeti has said, the latest one, we'll go through that and then take a call on it.
Yes,
Rajiv,
sir.
we'll move on to the next one.
We'll go to the next question. See, this question is basically because do you do some periodic checks in the staff in OT regarding their practices? Because we tend to drift away. Whatever were initially taught to them that this is how. So are you having some cross checks or something in the theater staff?
Yeah, Rajiv, I'll start. Yes, we have to because see, every alternate day we speak to the staff. So what happened is, as Sriram has rightly mentioned, they are worried only about when they face the patient, but they are not worried at all when they are talking among themselves. So in the OPD setting, when we clearly tell them every time that you have to make the distance, hand sanitization, everything. So suddenly during the lunch break, I found no one in the reception or in the OP. So when I opened the dining hall, I could see all the 10 staff sitting in a circle and eating. They said, we are worried only with the patient. You said with the patients, we are taking all the precautions. But now we are all having lunch together. That's how we used to. So yes, it is important that we have to tell them that everyone is potentially a positive patient. So not only with the patients you need to maintain all the protocols, but among the staff as well. So that has to be periodically stressed, either in the OPD or in the OT.
Anybody else has any comments? Any
Also, there is a
innovative
certain
idea?
amount of fatigue which sets in, sir.
Yes.
I mean, a lot of our staff in the beginning of May were taking all the protocols. But after 2 months of doing all this aggressive protocol, there is a certain amount of fatigue and they need constant reminders and rejuvenation to continue using them. And now when actually the cases are increasing, we are slightly eased up on the amount of protocols than what we were doing in the beginning of May.
I think there was a good article in Hindu by mom of Dr. Radhika, where she said that to motivate, try to have some award system, make some guide, like some markers you find out. Like one of the thing which I tried doing, the initial teaching was like the first in is your N95 and last out is N95. That means if you are putting the cap, the band should be below the cap. It should not be above the cap. Then you have really followed it. So just tried looking at that how many of the OT staff actually the N95 band is below the cap and above the cap. So only 50% actually did that. So we need to create some marker and keep on looking at and see if people are regularly following some reward system. That's what she mentioned.
Yeah, two things I'd like to add is that I think one, as you mentioned, continuous education is important. Continuous talking to your staff is very important, because not just about reinforcing the protocols, but also to assuage their fears, because everybody is exposed to listening to what's happening on television and social media. Sometimes there's a lot of fear. And I think especially in the younger members of the staff, especially in our setup, it's very important to keep talking to them, keep their channel open. They should be open and should be able to discuss their issues with you, and you have to keep doing that. Second thing is also have an auditing system. We have an auditing system where people keep checking whether these protocols are in place and that they're being definitively mandated. So in a larger system like ours, I think that is very important to ensure that this happens continuously.
I think just one point I would like to tell, because this is a new thing which has started last couple of days at SN. Every day, each staff who are stationed in the outpatient and inpatient, there is a small questionnaire that anybody in the family is unwell, whether your households, anybody or neighborhood. So once a nurse comes and takes these questions from everybody, fellows, consultant, I think because now we are getting more and more of these asymptomatic and households getting the disease. So there is no other way you will know whether any household is positive or not. So have an active surveillance in your system.
I have one question for the panel. How many are actively using this Arogya Setu app?
So I'll just start the quiz.
Yeah.
We have downloaded, but I'm not still able to find out the exact use of it, sir. Because every time you put something, it will say it is safe or so many around you. Everybody has downloaded, but the real use of it, we are unable to see from the patient, also from our own side as well.
It's one among the 100 apps in your mobile.
As far as
That's
the
all.
Arogya Setu is concerned, yes, we do ensure that everybody is there, because it's one of the government directives that all staff should have Arogya Setu on it. The second thing was that what Dr. Anand was saying, very true. Many of our staff actually, because within Karnataka, inter-district travel is allowed. Many of them go back to their families in the villages and come back over a weekend and things like that. Especially the nerve center of your entire institute is the OT. So you very well have to drill it into your OT staff that each time they are moving out and coming in, they're not only risking their family, which is there in the village, but they're also risking the institute here. So that has to happen, that the practices may have to change for a little while, that over the weekend they cannot go back and come back as and when they want to, because both the organization is at risk as well as the family back home is at risk, because right now Bangalore is a hotspot. The second thing is, which I found, to keep the morale of especially the youngsters who are getting psyched every day looking at the WhatsApp as well as the news, is what we have done is on the second floor of our building, we have put aside about 10 beds. Because right now the biggest challenge is to get a bed if you get positive. What's going to happen next? Which hospital do you go to? So we have earmarked 10 beds for the staff, for both the organizations, and said, look, if you fall sick, If you can't get a bed immediately, at least we will house you here. And with oxygen facilities and this thing, and our in-house physician will look after you. So don't be scared. Come to work without worrying. Don't panic if you get positive, because we are going to look you through till you reach a stage where you need to actually get into a hospital. And luckily now even the organizer, even I think the health ministry has come forward and said home quarantine is allowed. So that means it's not wrong. You can make facilities for them. See, the biggest worry is not turning positive. What after turning positive is the biggest worry. Whether I'll be able to reach a hospital, whether I'll be able to get a bed, whether I'll be able to take care. Most of these guys, houses are not big enough for them to be on home quarantine. And COVID care centers are not the best places to be also for them, because it is quite a big mess there right now. So I think the morale of the staff, if you have to keep it up, you need to make sure that you have gone the extra mile to make sure that they will be looked after even if they turn positive.
Well said, Krishna.
That's important.
Yeah. Well driven point. Rajiv, what are the next one questions?
Yeah. One of the things is, do you think pre-anesthetic checkup is mandatory now?
This is the thing which I wanted to share. Like, this is the latest wherein I marked it. Asymptomatic patients undergoing aerosol generating surgical bar non-surgical interventions. So in these cases, you can actually do elective bar emergency surgical procedures. They've allowed us to do. And this was released on the 23rd of June.
Okay.
Okay.
And I've also shared this thing.
Yeah.
Sure.
Yeah, we will see it then.
Yeah.
Okay.
So do you think a pre-anesthetic checkup is mandatory now? Many of the hospitals, they don't have a regular pre-anesthetic checkup, a PAC. Do you feel it is mandatory?
So
I think a PAC is very mandatory, Rajiv, because that's where everything can be. The physician can decide. He can look up on a couple of issues. Like we started doing chest X-rays for all the patients based on the advice of the physician and anesthetist. And a lot of findings, like they used to have enlarged heart or some fibrotic plaques. And these cases we never took up for surgery. We asked them to come later. A lot of other things we detected. And pre-anesthetic, I have an anesthetist for most of my VR surgeries. I have an in-house anesthetist who comes. So it's very important to at least to segregate the cases. I think a pre-anesthetic checkup is very mandatory. I think more than a chest X-ray, even I'm contemplating doing even an RT-PCR for all my VR surgeries from July. I thought I'll get the answer by the end of this meet, and now I'm still having. I'm not very clear whether to do RCPR for RT-PCR for all my cases. So I think a PAC is very mandatory. A chest X-ray gives a lot of things, and saturation. Checking the saturation is very important during surgery. And as VR surgeon, I have the biome tends to get more fogged often right now. Because we have the patient with the mask on, they keep on breathing more, and I find the fogging becomes more during surgery right now.
And Kaushal, other issue is the biome is the only instrument which is very closer to the eye. And the other instruments, we ETO, autoclave, and then use it. If you're doing 2 VR surgeries, what do you do with your biome? Do you autoclave in between the cases, or you just because we change the tubings for every case. Now, as Anand said, it's better to change the cassettes for all the cases. What about the biome?
Yeah, biome.
Yeah, Kaushal, you tell me, then we'll ask Anand and Sriram.
Yeah, but biome, I do, I sterilize. I don't sterilize again the biome. I usually wipe it with solution and then reuse for the next case.
Anand?
Yeah, same thing. You cannot autoclave between cases, and obviously it's not.
Biome cannot be autoclaved also.
No, the lenses can be autoclaved. The lenses.
You can put in a flash and use it.
It's better.
Depends on your model. Depends on what biome you're using. Yeah. Well, nowadays, because of lockdown, the numbers are not a big issue, Kasi. So what I am doing is I'm only doing 1 vitrectomy a day.
Okay.
So because of that, I'm able to escape, basically.
So what we do is that, of course, we surface sterilize it. After that, we put it in a formalin chamber till the next patient is moved in and get everything done, So it's in a formalin chamber, and then again you reuse it. So we don't really autoclave it in the real sense, but it's disinfected to a particular degree before we take it up again.
Girish, sir? You're muted, sir.
You're muted.
Sir is muted. Yeah.
We autoclave with each case.
Each case. Okay. So as Krishna said, we surface disinfect and then use the between the cases. Of course, there is a 15-20. Yeah. We have 15-20 minutes gap between the surgery, but we just wipe off surface disinfect and use the bio. And Rajiv, what's next?
So we'll just come to the last question we have. Have you changed the cost of surgery? We'll start from Dr. Preeti.
Sir, actually, our tariffs have not changed, sir. We have not. We have been very specific in that the tariff as such for the surgery is not changed, but we are including charges for the patient goes up a little because of some pre-op tests which are mandatory. Like we have made CBC and CRP now mandatory, so that hikes the cost a bit. And then even chest X-ray, we had suggested chest X-ray bar HRCT. This was even when we launched this protocol prior, like in the first week of May itself. That time RT-PCR was not available for testing. So this way the pre-op workup cost is slightly higher, and we also charge PPE from the patient for the surgeon and for the patient as well. So these we use only disposable gowns for the patient. We do not want to reuse again. So that gown we provide, and for the doctors also. Though we are actually reusing the PPE, we are charging from the patient for both the doctor and the patient. So that cost goes up a little. But the tariff has not changed. This is what guidelines we have given from our side as a group. And at each place, they do modify according to the medical director's perspective. And now that RT-PCR is available, some surgeons feel that they want RT-PCR. If they're able to connect with the local labs which are approved and able to get it done, they are actually getting it done and they are doing it. Otherwise, we have told them that you shouldn't, and suppose they are not able to do and they are not confident, they are trying to refer it to other centers where they are able to take it up. So this is what we have come up with.
Vasumati, have you changed?
Actually, patients are not quite willing to part with that extra money, but we do try to tell them. And the government has also given a provision. For instance, the CM scheme patients, there is a 10% hike in our tariff when we send the bills to account for the PPEs that we use. But for the other regular paying patients, we do suggest them to pay a little extra for the PPE. And as Preeti mentioned, for all our surgical patients, we do a mandatory chest X-ray, ECG, ESR, and a complete blood count. We do not do RT-PCR as of now for asymptomatic patients because it creates, I've seen personally, it ruffles a lot of feathers. So we will take it as it goes. But definitely the pre-OT evaluation cost goes up for the patient. And if the patient is willing, they pay for the PPEs.
Kasi, have you increased or not?
Yeah, same thing for the consumables, whatever the N95, because I give a patient 3-ply mask and then the gowns, whatever extra we use. So we just charge the patient, not as a surgical procedure, but to the add-ons to the we are charging to the patient.
Our surgical costs have not changed. Our surgical costs we have not changed. But where there is EUAs, examination on anesthesia and GA cases, the GA charges have gone up because they are in full hazmat suit. The anesthetist and the worker, the OT boy who is with the anesthetist when they're intubating and extubating, they're in full hazmat suits. So the GA charges as well as the examination anesthesias have gone up because of that. But rest of the procedures, we've really not changed much because apart from the N95 that we are using, not much has changed. So surgical charges have not changed much.
But there's a other story also to this, Raju, because current scenario, a lot of people are jobless. They don't have money also.
Exactly.
So once they are not able to afford to the existing cost also.
Yeah.
So rather than having a common thing, whether increase the cost or not, we have to leave it to the discretion, the paying capacity of each patient. If a patient is affordable, yes, tweak the charges. And if the patient is not affordable and you're convinced about it, reduce the charges. So that should be the way, because looking from their perspective, because now the paying capacity has also come down.
But Kasi, what happens is in slightly larger organizations,
you
will not be able to leave it to the discretion of 1% to start charging what they want. It's usually fixed rates for individual procedures and things like that.
Exactly.
So in smaller numbers, yes, it could matter.
Yes.
But if you have looking at it larger scale, it becomes difficult if you let it go to an individual who is contacting the patient. what to charge, what not to charge.
No, that's why
Yes,
why today the panel discussion is
Yeah,
institutes,
it
corporates, and
that
private
is why
practices.
what we have told is do not change the tariff, charge for the PPE. If the patient is not affordable, bring down the length. Like, for example, you have 3 slabs in an Indian foldable, you bring down to the lowest slab. See to that it is able to meet with their budget package. This is a clear instruction we have given, but we will not be able to cut down on the PP charges or the pre-workup charges.
Unfortunately, Preeti, in VR, we don't have that slabs.
That's right, sir.
No, I have not increased
No
my
longer
cost, Kasi, and
gone are
as
the
somebody
days of
was saying,
socialism,
yes,
social
affordability is a problem now. So actually, I am offering a concession to a few patients, and I am doing RT-PCR and CT chest for all my pre-ops.
Okay.
So actually, if somebody says that is costing them a lot, it's another 4,000. I tell them, you spend half of it, another 2,000, I'll give you a concession, but please get this done and then come for surgery. It is safer both for you and me.
No,
I put it across like that.
One point I would compliment Sriram also. When I was speaking to him, he was selling. He had a tie-up with one of the labs where they do as a package for COVID. So with the concession rate, am I right, Sriram?
Yeah.
So that also is a good idea that you can talk to one of the nearby labs, have an understanding.
Basically, because if he is screened, I agree. The RT-PCR, this thing is not 100%. It's not a foolproof thing, but at least to a certain extent, it gives you peace of mind. And well, if you can take a small cut in your pay, it is very good. But because it's all in the end of the day, it's much safer. Yeah. I look at it that way.
RT-PCR with X-ray should be fine for, do you think, for VR surgery?
CT chest. What I have done is I have negotiated with the lab to do RT-PCR for 3,000, and CT chest also the same center does a CT chest, doesn't give them a film or anything, just sends a printed report by email. That's all. The RT-PCR and this thing comes to my email. So it saves them cost. There is no film. We don't need a film. We just want to know there is no finding suggestive of COVID. That's all. If there's some other findings, then let him pay, let him take it from there and there on. That's a different thing. So they just send a typed report or by email. That's all. They don't even send a physical report. So that I have negotiated for 1,000 rupees CT chest.
That's too less, sir. Here they don't charge anything less than 3,500.
That's why you have to talk to the lab.
CT chest is 3,000. No, we have talked also, but nowhere.
Also, geographical distribution, Preeti, again, Chennai and rest of Tamil Nadu. Tamil Nadu, and rest of
1,000 rupees is too less for a CT. Here for digital X-ray, they charge 600 rupees.
Yeah, that's what I was telling. He had done a very good negotiation for his patients. Maybe we need to talk to the known labs and then try to get this benefit for our own safety and the
about a few things.
RT-PCR now the government has come up with 2,900, sir, for Chennai. But if it's home collection, they'll charge another 500 extra. So I tell my patient that if you want to be safe, you don't want to get exposed, pay the 500 rupees extra and get it done. So they come and collect from our hospital and they go, something like that.
Great learning, actually. Great learning from all the private or corporate or institute. Definitely practices seems to be same. Our aim is very clear, safety for us and safety for the patient.
Right.
Kasi, would you like to add some last words?
Yeah, last word, because all of us were telling if it's a COVID positive patient, we'll refer to a COVID hospital. So for the sake of all the audience, which is the COVID approved ophthalmic center. So that we'll send all the patients there.
RAO Chennai.
As of now, only RAO and nowhere else they do any ophthal care. And anyway, cataracts can wait, sir. If suppose a patient is having COVID positive.
Yeah. Let Preeti finish.
Anybody's got a COVID positive VR patient, I think you can send it to Clarity Chennai. Kasi will designate your place as a COVID center.
Sriram,
only COVID positive patients.
Sriram, you are in Trichy and I'm in Chennai. We are far apart, so don't worry about your practice.
As far as any cataract surgery or anything is concerned, it can safely wait for 21 days. So the infectivity, they say, is lost after 10 days of asymptomatic phase of the patient. So if the patient is COVID positive and the patient is cataract, you can definitely safely take him up after 21 days time. So we need not refer the patient for cataract to any other place. But obviously, for any other emergencies, the only place where we can right now refer to is ROGH.
One point which we actually totally missed. Sorry, Krishna. Sorry, I want to just say this point. One point which you totally missed. This is regarding what Preeti said. We can always wait for 21 days and then take him up. Yes. The main thing, it is not only about our safety and he infecting us. Any stressful event, like a surgical procedure, for example, even be it LA also, increases the risk of morbidity and mortality if the patient is COVID positive. The chance of an undesirable outcome during the course of, let us assume you've not done a RT-PCR, he is COVID positive, done a vitrectomy. The stress of surgery can actually precipitate a much worse course of the COVID disease and even probable death compared to if you had not undergone the surgery. There's enough evidence and studies to support this. So that is one good reason why you should actually always rule out COVID before taking up a patient.
So,
Yeah, Krishna.
No, one thing is sure, but yeah, acutely infected COVID patient who's symptomatic, unless there's a medical eye emergency, there is no need to take up for surgery. But if there is an eye emergency which needs to be addressed, I'm sure any organization here will address it, because if there's an eye emergency, you will take it up if you are convinced that you have taken adequate precautions to protect yourself. The second thing is that I can also probably assure most of the guys in the bigger organizations here that you've already operated on many COVID positive patients without you realizing. So you don't have to worry so much about it. But one thing is for sure, if in your mind you're sure that you are taking adequate precautions because you're taking protections for this COVID only, then when you find a COVID, why do you have to run away? You continue to take the precautions and do the care. No, you're not treating them like they're non-COVID. You're already taking precautions for COVID. So that means it boils down to the medical emergency. If there is no medical emergency and if the patient and you are comfortable pushing it away for some time, then fair enough. You will only do it again. You don't have to send it anywhere else. But if there is a medical emergency, I'm sure nobody in this panel will push the case away because they will take it up after taking further precautions if they need to. If there is a demand, if there's an open globe injury, you're telling me nobody will take it here, they will take it here. Only thing is that the risks are going to be explained better, risks are going to be understood better, and you will ultimately take it. You'll probably go into quarantine after that. You'll probably take medications for that, whatever you have to do. But medically is what is going to dictate which case you're going to take or not take. COVID positive is not going to dictate because there are many COVID positives. Every second person is going to be COVID positive soon. So you will have to learn to work with the COVID positives also.
That's a very positive affirmation. And one point, there was one question was about the mouth goggle. Is there any evidence? Because betadine and another one was Listerine. When I went through the Listerine yesterday, it has only 20% alcohol. You need to have at least 70% alcohol to prove against the virus. So Listerine may.
What do you suggest?
What are you suggesting, Kasi?
Or betadine. Maybe a betadine because betadine is proven.
I thought you're suggesting some other brand of alcohol.
That's well and good for both the surgeon as well as the patient here.
Not surprised from you.
And Clarity, people will start queuing up outside Clarity. Patients will start queuing up outside Clarity.
You are wearing respirators. The respirators. How many of you are wearing within the OT?
A lot of our high volume surgeons are actually wearing, ma'am. I can show you a picture where I can.
Yes, Sriram showed the picture.
Whichever center is high volume, some of the surgeons we were feeling safer when we operate in that way.
To be frank, actually, it is much easier to breathe through that than through an N95.
Exactly, and
bulky.
it is very,
it is not heavy.
very comfortable
it is not heavy.
also.
It's the full face or the half face?
Half face. If you wear a full face, you cannot go close to the microscope.
Yeah, that's what it's got that shield.
Yeah. So I can show you some pictures which we have from other centers. Like this is what.
I also have pictures. You finish, I'll finish.
So our means this is from various centers across the Agarwal Eye Hospital, where some of them operate with 3-ply, some of us operate with half-piece respirator. And is the screen visible?
Yeah, we can see.
So this is a center in Tirunelveli which is operating high volume. This is myself operating in Annanagar, and this is our LASIK surgeon who is at another, who is a high volume LASIK surgeon who is operating with the respirator. So as what Sir was mentioning, the comfort of the surgeon is more important and comfort of the OT staff is more important. We feel more confident when we are more protected. So that is why we have opted for this, and the cleaning of this also is very easy because when these respirators are, when these filters are removed, the rest everything is plastic. So you can just soak them in warm water with soap, and then you can clean it. And what is recommended is you have 3 pairs of filters. So like how you use the N95, one day I will use 1 pair of filter, the next day, the next, and third day, the third, and then we change over. See, some of us, as I said, because this organization has got around 81 branches, we cannot dictate terms. We tell them that all these are available and these can be opted for. And even in our main hospital, one of our retina surgeon is using this regularly. And some of our cataract surgeons are also using this.
And this is only for the
There are two
surgeon?
options actually. There are two options in this actually. Preeti, if you unshare, then I can share those.
Yeah,
two
yes,
different
sure.
options.
I'm stopping share.
No problem.
Yeah.
So
stop.
there are two options in that regarding the mask and the filter. 1 second. So this one is actually a 7200 mask. This is slightly more
No, you're
thicker.
not
It's
sharing.
more of plastic.
No, we are not seeing
Okay,
it.
sorry. Okay, now?
Yeah, fine.
So this is a 6200 mask. This mask is slightly thicker and this is a cartridge. This is easier to clean. The moment you finish theater, you take off this cartridge from this mask, you wipe it with a nice disinfected wipe and keep it aside, it's enough. The mask itself is plastic like what Preeti said. You can soak it in sodium hypo or any quaternary ammonium compound dilution and then wash it. And then wash it, that is enough. This is one option. The other one is, 1 second. This is a cartridge which I showed you. 1 second. I think I'll select everything at the same time. It makes it easier.
But to also add, honestly, some of the surgeons are, as what Krishnamurthy sir was saying, that they have the feel that they've already been exposed to the virus. So they operate even with a simple surgical mask or
This is a simple filter. This is the same thing. This is a 2091 filter. The problem is cleaning the surface of this filter is not that easy because it's soft. You cannot use an alcohol wipe or anything on the surface. So what I do is actually I take this out and put it in a UV chamber. This is also a similar mask, but this is a higher, this is 7500. This is more of silicone material. So this is much more softer and it's much more comfortable on you. There is no sweating. And actually the microscope fogging, even if the theater temperature goes up, is literally nil with these masks. Whereas with any other mask, I've always had fogging when the temperature goes up. You can wear a full face where the eye is covered, but that is more for the anesthetist when they are doing aerosol. Because here we are not able to go close to the microscope when there is an eye cover as well.
Sriram, only point disturbing me. Do you have only pink cartridges?
Yeah,
the pink is actually a color code. No, it is not. Kasi, it is not to do with the lipstick you're wearing. Actually, the pink, it's not pink. That color is magenta. Magenta has got, there are a lot of colors: black, white, yellow, magenta, green. Each one is a code on what it filters, like noxious gases, organic filters, inorganic filters, vapor, etc. So that's a color
P100
coding.
comes only in pink color. P100 is pink color only, sir.
It's actually magenta according to the 3M website. They call it magenta instead of pink. So that is for organic filtration, organic vapor.
Fine. Rajiv, shall we sum it
And
up
the
then?
filtration capacity is 99.97%.
Yeah, 99.97. Yeah.
That's right. So I think that brings to the conclusion. And as said, the main purpose or aim of this webinar is to instill the positivity and optimism. So no need to be scared, no need to be worried. Only thing, take all the adequate safety precautions when you do it in the OPD or in theater. That's the main purpose of this webinar. That's why we made it this as ophthalmology means optimism in ophthalmology. So that's the main purpose. And I think all the speakers and the panelists, they've done a wonderful job. And as I said, we have compared the practices across institutional practice, a corporate practice, and a private practice. So across the three practices we have compared, and as Rajiv said, most of us follow most of the things, and certain things are left to the individual discretion of the particular hospital or particular person. So otherwise, I think this is a fantastic webinar, and it's one of the most optimistic webinar I would say in practices as of now. So thanks to all of you, and again, thanks for sparing, and thanks to Intas, I should not forget, and extended time. We started at 11 and now it's almost 2, so 3 hours of nice discussions, and I'm sure it will give in a lot of optimism among all of us. And don't worry, keep practicing, but of course, take all the safety precautions. Thanks to all of you. And Rajiv, your final word before we conclude.
No, I already gave my final words. So thanks. And looking forward for the next RIG meeting.
So we will do something productive, and all your suggestions are welcome into the RIG WhatsApp group. So thank you. Thanks a lot. Thanks to all of you.
Thank you, everybody. Thank you.
And lunch will be served at the Perspective Homes.
Kasi, you have to go and start cooking now. Admit that.
No, morning I finished here. I woke up early.
Oh, good man.
My Sunday was
early riser, I think.
No, my Sunday was messed up. Otherwise, my Sunday is late because of this webinar. I have to wake up early.
I woke up late. Now I got to go and start cooking now.
Thank you. Thanks a lot. And
Bye,
see you
Krishna.
all.
See you.
Bye,
Nice seeing you.
Thank you.
Sriram.
Thank you, sir.
Shreyas.
Meeting all of you.
Bye,
huh?
bye,
Bye,
sir.
Shreyas.
Yeah, thank
Bye.
you,
See you,
Shreyas,
sir.
Krishna,
Papam.
and Kaushal,
Girish, sir.
Preeti,
Bye.
Pashmati
Thank
ma'am,
you.
all.
Bye.